You call the roll, please.
Mrs. Summers? Dr. Taub?
Here.
Ms. Newman?
Here.
Dr. Hans? Dr. Klotz? Mr. Rubin? Ms. Kacharik will be absent. Mr. Landsman? Mr. Furman?
Here.
Mr. Torres? Ms. Guadalupe? Ms. Bernard?
Here.
Thank you. I entertain a motion to approve the agenda. But I understand there's changes to the agenda.
Just ask if there are any changes, and then we'll approve the amended agenda, okay?
Are there any changes to the agenda?
Yeah. We're going to change the order on the agenda and have item C become the first item, and the other two items will stay in the same order.
I'm also asking for the opportunity to do a quick announcement based on a conference call we just had regarding rates. So I think the information at the beginning of the meeting might be helpful.
Ahead
New
of-
item A would be a announcement from the CEO, and then we'll move into.
After that goes down. Any other corrections? Entertain a motion to approve the amended agenda.
Move?
Been moved and seconded. Are there any other questions on the motion? Hearing none, all in favor? Aye. Any opposed? None, okay. So C becomes A. Okay.
Now, executive CEO announcement, then C, then AB.
We were notified late on Friday that the leadership at Michigan Department of Health and Human Services was hosting a conference call today at 12:30 to update the PIHPs on the new rate setting formula and the allocations for fiscal year '20. So we went into that phone call at noon. The good news is we found out that OCHN is anticipated to get a 5% increase in our budget. Now, I know when we met for study session, we had asked Anya to do some projections based on 2, 3, and 5%. So obviously, we haven't had a lot of time to react to the data that we just got. But I wanted you to know that there were several things that were discussed today. The money that MDHHS is putting into the budget is an acknowledgement, at least we're perceiving it as an underfunding of the system. So we are not the only PIHP who received increases. As a matter of fact, all the PIHPs received increases, but at different percentages. The total amount that was put in for fiscal year '20 is inclusive of the $49 million supplement that they have been talking about for fiscal year '19. That gives us hope and optimism that it is going to be approved. We sit here in September still not knowing how much that means for us this fiscal year, but the fact that they put it in makes us assume that they are going with the assumption it's going to be approved and will continue into next fiscal year. The factors that were used, they got rid of the old geographic factors that have not leaned favorably towards us in recent years. You are certainly aware of the rebasing that's happened, and the geographic factors based on diagnosis alone caused us to have reductions. The new factors seem to lean more in our favor. Now, the formula and the structure that they sent is 200 pages long, so I'm not going to overview the detail of them other than to say they do seem to give an acknowledgement that our region is serving people with a higher level of acuity, higher level of need. So some of these things we have said all along with regard to our region was accepting of moving people out of institutions early. A lot of people who have high level of needs remain in our region. It seems to be verified by this new formula. So to say we are pleased is an understatement. Obviously, if we talk to people from MDHHS or legislators, we want to show our appreciation. What I do want to make clear, though, is it's not a handout, it's not a bailout. It is an acknowledgement that the needs of the people we serve and the value of our public mental health system seem to be being realized with this new formula. So we are optimistic. Anya, again, has the information she'll share what we were anticipating, should we have gotten 5%, but we're thinking this does take us out of deficit spending, and a lot of things we've been worried about in our recent meetings and discussion will be rectified, or at least looking much better based on this information we just got this afternoon. So thank you to everyone for your advocacy, reaching out, and anything we've done with regard to promoting fair funding for the mental health system, because it benefits everyone in the state of Michigan, and we're really happy about this news.
See,
First of all, it is good news, and congratulations. Tell me, in terms of dollars, how much does that amount to? Is Anya going to make that presentation? Okay, good.
Yeah. And like I say, I went right from the call into another 2 o'clock meeting, so I haven't had a chance to crunch any
Oh,
numbers.
that's good.
Okay.
And when you say it's going to take us out of the deficit, Anya going to explain that as well? Good, thank you.
any more questions for Annette? I did have one. The $49 million supplemental that is basically for this year, if we get it, will it be paid forward into our fiscal year 20 budget?
That's what they shared with us today, that they put in 49 million. So we also got information on Thursday. There was some question how that 49 million would be distributed. The leadership at MDHHS said, obviously, it's up to the legislators and it has to be approved through CMS. They anticipate using the same funding strategy that they did for fiscal year 19, because it would be a supplement for 19. Now, the weird thing is, we may not find out until after the fiscal year is over, the amount for the supplement, and that's just the nature of the industry that we're in. But nonetheless, we are optimistic that there will be additional funding coming for this fiscal year, and then it will carry over into 20.
Any other questions for Annette? Okay. Can't take questions from the audience, but we will be going to public comment. Okay, thank you. This is our first opportunity for public comment. Anyone, Mr. Cummings, and anybody else at this time?
Hi, Fred Cummins, President Alliance for Malleola, Fulton County. I just wanted to bring your attention to something. You may be familiar with Lakeshore PIHP, which has been in trouble for some time now. The MDHHS announced some time ago that they were terminating their contract, and that decision is currently under appeal, so that the consequences are delayed. But the intent of the department is to give the PIHP responsibility to Beacon, which is a provider for Lakeshore, and has actually been kind of running Lakeshore for the last 1, 2, 3 years. I'm not sure how long. So it's not clear why that is going to be any better than what they've got now. If Beacon was in charge, what's going to change? Well, one of the things that's going to change is that there's going to be a lot less accountability of the public in that region in terms of the kind of services they're getting, the problems they have, who do they go to? The department is going to create a new board, loaded up with people from the department, with one recipient of services, I believe, and a representative from Beacon on the board, and some others. It does not sound like a board that's particularly responsive to the needs of that region. The intent is that Beacon will be in charge probably for the next fiscal year, and then they plan to bid it out. And they deny that this is privatization. because that's what it is. It's a clear move towards privatization with a bid out at the end of next year, presumably to some other private organization or an HMO. We're very concerned about that. When we saw that Lakeshore was losing their contract and there was all these problems, our proposal, I would work with a group of advocates, was to make Lakeshore a pilot project for how it ought to be done right. Significant changes to improving the system. One of those changes being that the budget be based on an assessment of the need of the community for mental health services, not actuarial decisions which are meant for insurance companies to figure out what risk they've got. Wrong way. Apparently Medicaid requires them to do that. They can continue to do that. But we want a real assessment of needs for that community to set the budget. If you did that for a whole state all at once, that'd be potentially a high-risk move. But for one PIHP, it ought to be doable. And there are a number of other changes that ought to be made to make that a more successful operation. But effectively, Lakeshore is the tip of the iceberg. They've got all the problems. They've had a lot of financial problems, and they're at the bottom of the list in terms of functioning effectively. But they're not the only ones in trouble. Everybody's in trouble. And this is just another move to shift responsibility to somebody else so the department and the administration doesn't have to take responsibility. So I suggest that it's in your interest and our interest that that move towards privatization be stopped. And if they're going to do anything, they ought to look at it as a pilot for doing the job right so that people aren't suffering from budget cuts. Thank you.
I'll just add, I know we don't respond, but for the board, you guys would have seen that all 10 PIHPs signed a letter in opposition of Beacon taking over the LRE region. We don't want to get in the habit of telling the state who they contract with, but it was the fact that they chose a for-profit entity from Boston to take over. That is the basis of our opposition. Obviously, everything we do is to advocate for a public mental health system. So we're supportive of the approach that Fred just discussed.
Annette, is there anyone else in the audience that would like to make public comment at this time? Seeing none, we'll move on in our agenda. The next item is to finalize the chief executive job description and next steps.
Thank you. You all got an email from me asking to submit any suggestions, refinements to the job description that we used in our last search. Thank you all for participating in that, and we did come up with a small list of suggestions. Edna kindly incorporated those into the job description, so if you have a copy of the job description that has red writing on it, then you've got the merged document. What we want to do today is finalize the job description so that it can be posted tomorrow. So if there's any discussion at this time, I'm pretty much open to it, whether or not we want to keep these suggestions, if we want to revert back to the original document, whatever the pleasure of the board would be at this time, but we do need to finalize that today so it can be posted tomorrow.
Did you want us to take the time to read through it now since we just got the?
Why don't we take it by section? If we just go by section. We had the list of comments in our packet that was emailed to us. And they are now, all those suggestions are just in the proper portion of the job description. And
We have a quorum now, by the way.
thank you, Sarah. Thank you, Bajaya. Are there any comments on the essential functions? We have 2 items that have been added. Do we find those? Malkiah can.
Oh, I see it. I didn't see your hand.
purpose. Let's just take it section by section, if that's okay.
Right now, we're in, I'm sorry, essential functions.
I don't know if this question is appropriate, so stop me if, if it's not. But I'm just wondering, can we ask Annette if there's anything, since she's been in the position, I mean, do you feel that that encompasses your essential functions, or is there something that could be missing? Surprise to someone that wouldn't be.
I apologize that I did not look at it with that eye. I certainly could, you know what I mean? And, I mean, it's a very broad job, but I'll look at it as you guys continue to discuss. I didn't look at it from that perspective. It's kind of, the board has been in development on it, so.
Again, if that's not appropriate, I just, since she's been in the job, it might be, if there's something that jumps out that is huge.
Just raise your hand if you have. In terms of the addition, are there any comments about that? Keep? Not? Any thoughts?
I think it's a good addition. Brings more clarity to what it is we're looking for.
Others? Any reason not to keep it in? I think it does add clarity too. I'm in support of those changes. So we have agreed on that, correct? Next, we go to the section on experience. Are there any comments regarding these additions?
Again, I think this adds clarity. We had a lot of discussion about the experience with the community mental health in our study session, and I do support putting it in a separate bullet. So other than that, I don't have any issues with what's been written. Sarah?
I would just have one comment under training requirements. We don't have anything there, so either take that out or add something, but I don't see any bullets under training requirements.
Comment on that. I think what we can do with that is to just add none. There was some discussion as to whether to put specific licensure requirements in there, and since it's not technically a requirement, we can add none to make it clear.
I think that would just look better, because the way it looks
Blank.
is just kind of, yeah.
Looks like we skipped it or forgot it or something, right, exactly. Is there any other discussion regarding putting none under training requirements? We good with that? Okay. Experience, and thank you for bringing that up. I overlooked that myself. I think, too, that it adds specificity and clarity to the experience that we're really looking for. Is there?
Advocacy, legislative, and crisis fiscal management acumen. I would like to suggest that that be moved into experience.
Conversation on that? You want to keep it, those items included, but you want to place them under experience?
Yes.
Okay, just want to be sure I understood.
Just for, ma'am,
Absolutely, please.
for clarity, the difference between what you're looking for is someone who's actually performed in these areas as opposed to technically having knowledge of those areas. So that would be the distinction.
Part of the verbiage should be at the minimum under experience. And as far as knowledge of public advocacy, legislative, that can stay under knowledge.
I'd be interested to hear if anyone else has any comments about that. Are you looking for someone who has actually performed in these areas? Is that something that's critical to the board? Or
Physical
would you be?
Physical management? I mean,
Well-
crisis fiscal management?
I mean, there are areas in here that speak to having competency and the ability to manage crisis situations. For the purposes of putting the posting out, I'd just like to get, clarity and understand from the board where you would like that to be.
I could be swayed, but I'd like to see where.
I'm just asking for,
I
for,
think
for, cl- I just want to make sure that that is what the
Stop me
board.
if I don't get this quite right. I think what Edna is suggesting is that, do you want someone who has experience in public advocacy, legislative, and crisis financial management acumen, or do you just want them to know about it? Do you want them to have an awareness of it, an understanding of how best to incorporate it when the need arises?
That's it exactly, so I know where the board would like to have that indicated within the posting.
Of that could be taken, where we leave that there, but potentially, like, I think crisis fiscal management is important, or some type of fiscal management that, like, that key component could be taken out and put over under experience as its own, but not necessarily, I don't know that it has to be all three. Responsibility is a huge component, in my opinion.
Steve?
And somebody might actually not have the experience because they might have been such a good financial manager that they never had a crisis. But they were prepared, they may have been prepared to handle it if it arose, and they never experienced it. And that would be great for us.
Quite amazing, absolutely. Further discussion on this point?
I was just going to add, I guess, if you're moving it towards required experience, just think of the pool of the applicants that you get. So if indeed you're narrowing yourself, if you're requiring somebody that has crisis fiscal management experience compared to if you think of the clinical background of some people that could be applying. So something to weigh, whether it's a requirement or a preferred.
We have people on the staff that have obviously lived through financial crisis management. A leader that might have knowledge of it, not experience, could go to and still make a good team. So I go either way, whatever the board wants, but I think where it is now probably makes sense.
I like the idea of the awareness so that we're not, someone who hasn't had the exact experience, we're not forgetting about them. So I like where it is right now as opposed to experience, or just put in the word awareness.
What is the consensus?
Along with the word aware.
How would it be
Yeah,
worded?
could you read your sentence with awareness or aware in it, please?
The point of crisis is the word that's needed, other than fiscal, financial management.
Strike crisis, your suggestion is just strike crisis.
Right.
I miss where, was there
Financial-
some, okay, go ahead.
Reading financial, fiscal management. I don't know what acumen means.
Cutting edge.
Myself, so it says ability to make good judgments and quick decisions, typically in a yeah. I thought
Well, I
I knew,
thought
but
it
I
made
wanted
it
to
sound-
make sure that
I thought we
was on
sounded
the
pretty
same page.
smart.
Yeah.
That we were, if you, it's a word you have to look up. I think that's,
Judy,
You all set on that?
I
no,
have no idea.
no.
Are we striking crisis? Is there agreement to that? We're striking crisis? We're not striking crisis.
Crisis for a while. Crisis financial management is different than handling regular financial
agree.
management.
I would agree.
Judy, that bullet doesn't start out with knowledge of, should, like the rest of them do, should it have, or is there a particular reason?
Just for consistency.
Okay.
should I say familiar, oh, knowledge of, right? 'Cause it's-
Okay, knowledge of public advocacy, legislative, and crisis fiscal management acumen?
Yeah.
Okay.
Leave the crisis in, at least have a knowledge of what to do in that type of situation.
Are there any other comments on that? Now, I heard the word awareness somewhere discussed. Did that have a place in these two?
I think if you add in knowledge of,
Yeah.
it's just like awareness of, so
Okay,
it
so,
works
oh, I see,
perfect.
that was the
Instead.
introduction.
We don't
I
want
got
that
it.
to
Okay,
be-
great. Okay, so we'll just make that change for clarity and consistency. Keeping it.
So my understanding of the desire of the board is to have these items under the knowledge requirements. It will read knowledge of public advocacy, legislative, and crisis fiscal management? Okay.
Be
that
on
correction.
board with that?
Are we leaving acumen in?
Acumen's cool.
Okay,
That's one of my favorites.
just checking.
Like, if you have to ask, that's
Okay.
exactly right, yeah.
I use it.
Now
every
that we
day.
know. Yeah, use it 10 times in a sentence
That's
between
good.
now and next week. That's really good. Are we in agreement?
Yes.
Okay, good. I'm glad we're having a little fun with this. It's kind of a dry topic. In the next section, competencies, skills, and abilities, we've added proficient in the use of Microsoft Office Suite and the other examples. Good for clarification?
Question. There's another program, and I can't think of the name of it right now. Maybe you can help me out. And I don't even know if it's part of Excel, but it's the graphics. There's a program.
Are you talking about for dashboards?
Yes,
Power BI?
yes.
Yes.
Do we have to name that in here?
I don't think you would have to, really, it would be more about, and I'm sorry, I haven't read it. Really with that, you're getting more at knowing the data analytics and the trends and the so on and so forth. I wouldn't expect for the CEO to have to be an expert in Power BI. We're going to have those in the organization. Help?
We've also included et cetera.
Not as good as acumen, but it certainly serves a purpose.
And so on, and so on, and so on. Okay.
Other comments on,
So what you're saying is staff, someone on staff will have.
The only comment I'd like to make, since it was pointed out to me so clearly, in the study session, we don't want to narrow the pool. We want to make sure that we get a good pool of candidates and not leave someone out that might not be strong in certain areas, so, yeah. More is better. Steve?
Yeah, I agree with Malkia. This does narrow the thing, because like I couldn't apply for this job. And it says proficient. So if I wanted to, I could be a leader and want to have a PowerPoint and have somebody on my staff make the PowerPoint for me and just learn to give my presentation from it without being proficient in the use of PowerPoint. So I agree with Malkia. This might actually take somebody that would be perfect for us that doesn't know how to use PowerPoint or
that's direct awareness?
just know that it exists.
Yeah. Edna, I'm sorry.
To address that, we could remove proficient and add knowledge of, and the board gets to decide the breadth of that knowledge.
But you would want people to have some knowledge
Right.
of, I mean, it's the basic tools. You want them to have some knowledge, but some of the applications do have quite a bit to it, so I wouldn't want to hold someone's feet to the fire over something like that. Thank you, Edna.
So we're discussing that statement being knowledge of Microsoft Office Suite, for example, and et cetera. Correct? Leaving it at that, are we good? Are there any other comments those are the changes that were suggested by the board. There were a number who were quite also okay with the job description as it was written, but I think the additions are good. I like it's collaborative, that's always good.
I have one other comment. I do notice an omission. We have revised all of our job descriptions since Annette has served as our CEO, and among them is in line with the less labels, more respect. So under our core competencies, the second bullet, customer focus, we do have an item saying that we recognize that the ultimate customer, formerly that used to say the ultimate customer is the consumer, now we say individual served, so I will make that correction.
Yeah, Annette.
In follow-up to Sarah's question that she directed to me at Essential Functions, I have now reviewed them, and the reason I didn't answer quickly is I wanted to make sure things such as serve as a positive and influential representative for the interests of people served are in here, and develop and strengthen trusting relationship with key partners, stakeholders, and community-based. So those are the things I was searching for, and they are in here. So I do feel this is a nice summary of essential functions for the role.
Thank you. Are there any other, I'm stepping on your role. Are there any other comments regarding this?
I will just say, if the board does approve this language, I will have that ready up and posted before noon tomorrow. It will be on our website.
Are we in agreement that this document as amended is the document we want to post for the CEO? No, we are going to agree. Yes, this is the end of it, end of this discussion. And two of the members not here also were fine with the document as it was. So I have additional feedback, but if there's agreement here. So I think, Edna, do you have all the information you need to post?
I do.
Okay,
And I
thank
will
you.
get on it.
I think that I did meet with Edna and Annette prior to the meeting today, and we talked a little bit about next steps. And at the study session, we discussed the fact that we would be, as a board, as a full board, we discussed the possibility, I should say, that the full board would in fact supply and review all the interview questions. And in the process of doing a little research on my own and talking to a lot of people, I am suggesting that we also reach out to the people we serve, to our staff, and to our provider network to see if they have questions. And I believe Annette said, and I think Edna agreed, that we can use SurveyMonkey to gather that information. So we will have that prior to the study session, and we will be able to make the decision. We should talk about how many questions it's feasible to ask, but I'd say if we could find a way to do 50-50, half board generated, half individuals that we serve, the staff and the network do it 50-50. I think that would be a really good blend. And we will have the opportunity to look all the suggestions over in 2 weeks, or 2.5 weeks at the study session. Also, I had a couple of other comments that I provided to Edna. So in the coming week, by the end of the week, we will put out a new proposed process for the search, and we will discuss that at length at the board meeting and make the final determination at that time so that we're agreed about how we are going forward. Other than that, am I leaving something out? I think that that's really what I wanted to tell you. So stay tuned for that, watch for it. I'll probably be sending it out with a little bit of an explanation of what kind of went into my thinking for suggesting some of the steps, and we will be ready for that feedback and discussion at the board meeting to finalize the process so that people are aware that we're taking this seriously and we're moving forward with it. You know, we don't want anybody to be feeling uncertain that we're doing anything but taking this very seriously. I mean, a lot of people are watching us. The people we serve, our staff, the network, the department, you know, it is also quite likely that people who are going to apply are watching how we're doing this. So putting our best foot forward and coming up with a solid process that we all agree to in a collaborative way and try and make the search process as inclusive as possible is, I think, what we're striving for. Because in the end, we really want to attract the best possible candidate to move us forward and to make sure that our mission and vision and values are advanced. So stay tuned. I think that's it for me. Thank you.
Thank you. Are there any other questions or comments? See it?
I just want to say thank you to Judy and Edna and everybody else who participated in this process. It was well thought out, and we all had an opportunity to give our comments, and they were well taken, and it assures that all members of the board will have input in the selection process. And thank you very much.
Anyone else? Thank you, Judy. Our next item is the draft annual plan.
Hi, thank you so much. Anya and Diana are also going to assist in the presentation of this plan. And I first and foremost want to let you know how honored I am to lead this initiative. Over the years, I've now participated in the development of nearly 13 annual plans and at least three-year planning cycles. So at the heart of all of this is getting feedback from, first and foremost, people served, family members, advocates. We certainly listen to board members and your input, not just one time as we develop this plan, but certainly throughout the year. We've also had the opportunity to sit with staff of this organization and others to get their input as well as provider input. So please rest assured, at the heart of this are people served. Last Friday, I had the opportunity to sit with a group of people at an appreciation luncheon, and it dawned on me that so many of the people sitting around that table have participated over the years, and that they have really set the course for this organization, not only for this year's plan, but into the future. So as always, people represented, input from people served is first and foremost. This, in going through these slides, and we'll go through them very quickly because I know we have a certain time allotted, please know that we always look at inspire, hope, empower people, and strengthen communities as our mission. And it continues to be our mission this year. There's been no suggestions to changing that, and it sits at the heart of what we do. Our vision statement is to be a national leader with quality health care and mental health care, supporting all the people that we serve. Core values have not changed. We talk about, I won't go through every one of these, but to promote equity and personal choice, dignity and respect of language, certainly person-centered planning, guiding the goals and needs of people remains important, protecting rights, affirming rights of people, leading this organization with integrity, accountability, and transparency remains important, strengthening our community and collaborating in shared purpose. Many of you know that this annual plan represents part of the three-year strategic planning cycle. This plan is always approved by the board. It is presented to the public in a public forum, and certainly we're talking about it today in prelude for a board approval later this month. This fiscal year plan is the second year of our strategic plan. This slide talks about goals and objectives that remain at the heart of people's wants and needs. In many of the surveys and in talking to people, these remain front and center, and certainly those things called social determinants of health, housing, employment, and transportation are central to the happiness of all people. This plan is a 12-month plan, so when we establish the objectives that accompany the goals, we look at an expected completion within the next 12 months. We have a set of principles that serve as the basis for the work that we do. Some of them include person-centered planning, self-determination, family resiliency, a trauma-informed treatment and work culture approach, recovery, not only for people who have challenges with substance use, but certainly mental illness. Additional principles, and some of those that have been added recently, are the Zero Suicide Initiative. Peers services continue to be front and center. Community participation and belonging is a nod to home and community-based waiver services, and fiscal responsibility and efficiency and the wise use of public funds are also at the heart of what we do as an administrative approach. These are the strategic priorities from the last strategic planning cycle: administration and operations, advocacy and empowerment, budget and finance, healthcare and wellness, supports and services, and technology and innovation. The first area is in administration and operations, and with the 4 bullet points, you can see the goal and objective areas that we'll cover. The first area is accreditation. Many of you know that we have had a long-standing objective and part of the strategic plan approach around National Committee for Quality Assurance. We had a recent site survey review, and the objective in this next fiscal year is to really address the recommendations of the site review. Anya is going to talk about value-based contracting and fiscal responsibility.
Okay, as we have been including in our last several annual plans and is in the strategic plan, we are continuing the evolution of our outcomes-based contracting, and for this fiscal year, that means developing a service model for the network for substance use disorders. The hope will be to develop and/or pilot, if possible, sometime this fiscal year. And in addition to that, we want to make sure we are reviewing the data we have collected from the service models in prior years and adjusting and moving those service models along as we are able. The next one I have is financial reporting. One of the things that has changed significantly over the last few years is how we pay providers. So that's much of the work you hear me talk about doing with our consultant in order to restructure our internal systems to make sure that we can document and track how we are paying providers at this point to be as efficient as possible and hopefully reduce the amount of time we spend on state reporting, because it is increasing, not decreasing, and increasing with significant amounts of detail and requirements. So we are restructuring that and redoing our year-end reporting process you guys have heard me talk about before.
And the final area in this strategic priority is provider network development. There's 3 objectives. The first is to monitor performance around what is called health effectiveness data and information set. Those are the HEDIS measures. We will also continue to monitor compliance or adherence to home and community-based services transition plan. Many of you have heard of that through the years. And finally, we're going to implement any needed changes with the Centers for Medicare and Medicaid Services 1115I waiver. And we have seen over the years that there's been more of a centralization approach, and what that will mean to this organization is more of a centralization of the application process and reapplication process, which is currently delegated to a core provider organization. So this is the first area. I think we'll stop here and see if anyone has any comments or questions relative to this first section.
Well, this is a very aggressive approach, and I'm sure it took a lot of time to put this together. And, I want to know more about, earlier we heard that we won't get the money, the increases, the 40, or part of that 49 million until our next budget, correct? Or did I not hear that correctly?
So if I can address some of that now if you'd like. Otherwise, I'll talk about a lot of that in detail when we get to this financial management section in the agenda, because that will go into not only this fiscal year where we're going to end up, and then next fiscal year's projections that we talked about at the study session.
That's fine, but I'm looking at this very aggressive approach. And what I'm thinking about is, how do you accomplish it without the money? And when I say without the money, we're not going to get that increase until the next fiscal year. How does that affect our providers when they're hurting for money in order to fulfill their programs that are incorporated into this report?
Well,
I want to
clarification.
wait to answer that, Anya, that's fine.
So let me just address real briefly. The day we get the cash does not necessarily impact the revenue and the expense in the fiscal year. We will accrue it at year end, that it is coming, because by year end, we will know the amount, but that's just a cash transaction at that point. We will know the amount, we will book it, and then it doesn't impact providers at all because we still pay providers on time. We've never missed a payment date. So that's just when the cash actually hits our hands. We will book it into this fiscal year, even though we're not going to receive it until fiscal year 20.
You're saying that regardless of when we get the monies, core providers are going to get advance payments, or they're going to get their payments on time?
Correct.
What if you don't have any funds to dip into, like reserves?
We have the cash to do it, and we continue to receive cash every month. This is the supplemental amount that you're referencing that's above and beyond what we're currently receiving. So those things it's just a matter of a cash transaction. This still counts for fiscal year 19. Just because we don't get the cash until fiscal year 20 doesn't mean it doesn't go towards the fiscal year 19 expenses.
Bookkeeping, I understand that. That's accounting and bookkeeping, and that's fine. But I'm talking about cash.
Right, and we're
To
not,
operate.
and we're still going to make all of those obligations as planned.
And many of these objectives are current, that some of them are ongoing with the current staff structure that we have and the current budget that we're receiving.
Jaya had her hand up. Jaya and then Jonathan.
Goals and objectives, how will we measure the outcomes on these objectives that we have outlined?
I'm sorry, which one are you talking about?
The goals and objectives, your PowerPoint 9, slide 9.
Slide 9. We
Criminal
have-
justice, employment, evidence-based practices.
We don't have, at this point in time, a specific objective around particular evidence-based practices, but there are expected outcomes with those, and we're able to, with our data, measure whether those outcomes are met. For instance, I know with some of the incentives, we have built-in incentives around have they advanced evidence-based practices, and then there's certain outcomes one would expect with those evidence-based practices. For instance, if it's assertive community treatment, according to these SAMHSA guidelines, decreased hospitalization, decreased crises, stable housing situation, employment, staying out of the justice system. Those are expected outcomes, and we're able to track that. And then, of course, with every annual plan that we have an implementation plan that goes with that. So everyone who is a champion for these particular objectives then is responsible for completing those objectives and reporting out on them, which most of them you hear throughout the fiscal year because staff come before you and report where they are and what some of the outcomes are.
Jonathan?
Thank you. So I wanted to clarify or make sure I had a clear understanding of the question that Sid had. So we've been paying our providers throughout the year. We're dipping into our reserves to do that at a loss right now because we're using up the reserves. To pay them, we're using cash on investments that have been maturing. So we're not prematurely cashing those things in. So because we're doing this. And when this money comes in, that's cash, it'll go to essentially recover the reserves that we've been dipping into. Okay, thank you.
Steve?
Yeah, just, it may be superfluous to mention this, but this annual plan that we're being presented is for next year, not for this year.
That is correct. It begins October 1st.
So any money we get on what we're discussing applies to the year we're about to finish.
Correct.
So far, I'm hearing bookkeeping entries and, journal entries, bookkeeping entries, fiscal year, and that's all fine. That'll show up wherever it shows up, and that's fine. But my concern, and I hope you address it, is that if one of our providers comes to us and says, I need a $500,000 advance, and proves to you why they need it, where is that money going to come from?
We do that now as needed. That's not a new thing. That's the difference between cash and the budget. So we manage the cash flow as needed as we get payments in and as we are receiving money from the state and whomever else. If they need cash flow, they pick up the phone and call us, and we do manage those things. So this is no different. Nothing has changed compared to what we've been doing. As Jonathan pointed out, we have used matured investments to pull cash in because we have a deficit budget currently, and that has afforded us the liquid cash in order to be able to continue pay providers at the rates they currently have.
Well, I get that. We did that, done that, and I saw that. When was the last time we purchased investments?
We have purchased investments in, 2 years.
2 years.
We've had a deficit budget for 2 years.
We haven't purchased any new investments.
Other than the transitioning of the current investments to the new
The
company.
ones that expire?
The ones that come mature, we take the cash
Sure.
because we need the cash in a deficit budget.
So getting back to my question, where will that 500,000 come from? What fund?
I don't understand your question.
We don't have 500,000, so we're going to take it from some fund. We used to take it from reserves, and maybe we'll still take it from reserves. Where is it coming from? Is it going to still come from reserves, or do we have to take the money from maturities and cover that?
Anytime anything matures, we do take the money so that we are able to have that floating amount of cash in order to do those things. So we do have the $500,000. That's what I'm saying. We do manage cash enough to be able to do that for providers currently and going forward. That's part of what we do with cash management.
Let me try to wrap it up differently. Do you invest monies that are in reserves?
Currently in investments, all of the reserves
all
is
in
in
investments.
investments.
Okay.
As it matures, we have them give it to us until we are out of a deficit budget and don't need it.
So if a core provider is running tight on money because of the state, the government, all these other people who are not generous enough to give us what we want, okay? All the other, 9 other operations, what they want. They have to wait until we have maturities if we don't have the cash, correct?
If we didn't have the cash, that would be correct, but that has yet to happen. We get requests more than once a month to pre-fund people so that they do have cash when they do have cash flow issues. We do this on a regular basis.
Did you have a comment? Okay.
Okay, okay. Moving into the second priority area, this is advocacy and empowerment. And we also have a high number of goals in these areas. The first is relative to civil rights and guardianship. We have, over the last couple of years, focused on what is now called supported decision-making or alternatives to guardianship. We have a very active local committee that's tied to a statewide group, and the objective is to increase the number of individuals who are involved in supported decision-making options, and thereby the reverse is to decrease the number of people who have guardians involved in their lives. The next area is advocacy and empowerment, community education. Do you want to do this? Christine, do you want to? I will click. If you want to talk about this, this is your area.
So we do continue to lead the advocacy work group, which I have mentioned before. We have about 125 members, committee members at this time. We had 5 subcommittees. We recently added a parent committee. We're very excited some of the outcomes of their efforts. We will be launching a marketing campaign that my team will be working on, probably October, November. We also implemented the person first language. A lot of these conversations and outcomes are the results of the dialogue that goes on during those meetings. So we're excited. We have 4 meetings booked for next year already on our calendars. We have guest speakers come in and talk to the group, and really it's just in time to collaborate and listen carefully to the people we serve and their family members.
I'm sorry, Hadass.
Some specific questions on that. So that's wonderful, and thank you. So just regarding, it says develop and launch a direct care professional employment campaign. So I'm not familiar with what that actually means, if you don't mind explaining what that means.
One of the conversations we've been having during the work group is how do you recruit people, and that does go beyond salary and wage. And what we've talked about is when you look at fast food organizations, people use that a lot. But if you look at their marketing structure too, in the conversation, it really makes people want to do that job. So what we have decided to do is implement posters, social media, messages, and then our goal is to have a portal of sorts on our website. We'll talk with all of our providers, and then if somebody wants a job as a direct care professional, they could come to our website, they could click on that, and then there would be logos and brief descriptions of all of our providers whom we work with as a connection point.
Right. And I also had a question about how you're going to continue recruiting new members and growing the parent-family subcommittee by September of 2020. So how many, like, how large is it now? How big do you want to make it? Just kind of more specifics.
It is brand new. We identified a parent, Rhonda, her son Tyler received an award earlier this year, and she had applied actually, I think, for a role on this board, and we were aware of that and contacted her and said, would you still like to be engaged? Which she said yes to, and so we're in the process of developing a flyer right now with her input. So hopefully that will be more family, ally, parent-led and driven.
Are there any other questions for Christine? Oh, I'm sorry, Adam, I couldn't see you.
Actually, had one on the previous slide about advocacy and empowerment, where it says, I know we talk in the descriptor about alternatives to guardianship, but I'm wondering about maybe changing that heading to civil rights and alternatives to guardianship.
That's a great idea, and we'll go ahead and do that. How's that?
Thank you.
You're welcome. Appreciate that input.
And I had a question about the number 3 under community education, expand existing efforts to address the current loneliness factor.
So we recently, we were reading information about loneliness becoming an epidemic in our nation. We already have someone, Sherry Rushman, does current workshops about loneliness, so we are going to work with her to expand on those workshops and tap into her expertise.
Any other questions for Christine?
I think currently the Center for Disease Control has identified loneliness as an epidemic. So when she refers to that, it is from the Center for Disease Control. And it's seen as a factor in the social determinants of health. We're seeing it more and more.
I'm sorry, I guess I was a little surprised because I hadn't heard that. And it hadn't come up in a meeting that I'm aware of, so just to see it in the annual plan that way, it's like it came out of nowhere for me, but I appreciate the background.
I'm sorry, that was actually when the survey went out for the annual plan and we were putting that out, it was something I suggested after reading it in the CDC, so it was something that was a result of the survey and input. Say, I've seen data, things that they're using loneliness as a factor comparable to like cigarette smoking and leading to ill health and even death. So on the national level, it's being talked more and more about. And it's really good conversations and efforts.
With that being said, I take the liberty of saying I'd like to see a presentation at the board level around that issue, because we don't just have these meetings are televised, and the information goes out to quite a few people, so I think it's important enough to have that discussion around our table.
I'm certain that Sherry Rushman would like to be part of that discussion. She does have a module that she trains. It's called Defeating Loneliness. And actually, I was trained in that and participated with a number of people at one of the drop-in centers. And it's very eye-opening. Even in our culture today, I think about, do I know my neighbors? And how am I connected to my community and those things that I can do better? So it's for everybody, quite frankly.
Thank you.
We'd be happy to do that.
Thank you.
You're welcome. The next area is peer supports and services. Many of you know that this has been a part of our strategic planning for many years. We started with peer support specialists, then there were peer mentors. We have a few in this room who are. Parent guides, youth guides, and more recently we've had someone trained to be a health navigator. So we see the expansion of the role, but we do know we need to come back to basics. And in talking to Vicki Suter around this one, we selected a measure that is in one of our contracts or soon to be in our contracts. And we kind of circled back around to peer support specialists and increasing the number of people who are involved with peers. Certainly also looking at the number of peer specialists and increasing that. Just because we have this specific objective doesn't mean we're not focusing on all people served who may want to be peers or have a peer in their life. Next area is person-centered or family-centered planning. We are going to increase the network of available independent facilitators. This swings back around periodically, and we know we need to pay attention to this again. And also, we want to develop a person-centered, family-centered planning curriculum and training plan, kind of swinging back around to an objective we had several years ago A couple of us at this organization were involved at the state level. We thought there would have been a statewide training plan at this point in time, but we know that we can't wait, so we're just going to come back and do it locally. So you'll see more developing around that. And then finally, self-determination. We want to always increase the number of people who direct their own lives through self-directed arrangements. And we are also looking at the possibility of issuing a request for proposal to an organization that really wants to focus on the development of self-determination and working with people in their understanding, acceptance, and selection of self-determination. That's the end of the goals and objectives in that particular area. Are there any questions, further questions?
One or two. With the peer supports and services, I noticed with the org chart that was sent out, I didn't see any designation in there. I know that it falls under Vicky, but it was not specifically spelled out on the org chart. And I'm kind of questioning that. It's, because sometimes to me, I understand that it's here and it's in the plan, but I can't shake the feeling sometimes that it's kind of gets lost in the shuffle, and not to see it in the org chart kind of reinforce that feeling with me.
Edna, do you want to address that? And maybe I can fill in if I have some thoughts about that too.
Yes, we do have several positions. Some of them report to Vicky, some of them report to Mike Daly. That we currently have people receiving services operating in those roles, and they connect directly with peers. We don't necessarily have the title peer support specialist for those. We have some peer allies who are working for us, so we can make sure that we find a way to designate that in the org chart so that it's more apparent to individuals who view that org chart, so that they know, just by looking at the org chart, which one are peer supported services.
I was going to say, and we also have people who report to Nicole Lawson in utilization management and our initiatives in healthcare integration. We also have our training department, those who report to Tricia. So I'm going to own this a little bit, because when I started, there were still some positions that said things like consumer education specialist, and it was somebody who received supports. And I said, we're not having any job titles that have the word consumer in it. If you're an education specialist, you're an education specialist. But just like when I sent the org chart, we kind of highlighted which are seasonal positions. We can certainly go through and give you color coding so that you can see that we rely on peers. Actually, even facilities management, some report to Mark. So I think that'll be nice for everybody to see. So it's a nice suggestion, and we can color code to make it clear.
I would just like to also add, though, that those are identified peer support specialists or peers. There are people who work in this organization who've had lived experiences but choose not to self-identify. And I think that's important to understand. That brings a depth to this organization also. But I do understand in an organizational chart, it's hard to see that.
Mm-hmm. And the other thing too, don't we have a person designated to the state that's a peer liaison in this organization? Because that didn't show up either. It was my understanding that that was part of Vicky's role, a peer liaison to the state.
I'll have to double check with her on that. She certainly is well known at the state level around peers, supporting peers. She actually has a very active role at the Tri-County level. We often host Tri-County meetings here of all the peers in the area.
Thank you.
You're welcome. The next area is budget and finance, and Anya is going to talk about the goals and objectives in this area. Sure.
In finance this fiscal year, as Annette mentioned in the beginning of our meeting, we are just now getting a glimpse of the rates, and it is completely new methodology and area factors for this fiscal year. So we will spend a little bit of time in the beginning of the year here analyzing those new rates and decoding them, for lack of a better word. to make sure that we're understanding how we're being funded in specific categories, age, gender brackets, area factors, and things like that, because our intent is to really automate the revenue projections, so we have a better way to monitor and modify what we're looking at for the fiscal year. In addition to that, what we have to do, it's due in December, one of the state reporting requirements is our risk plan. So the risk plan is very dependent on understanding where we are for the fiscal year from a revenue and expense projection. So that will kind of go in line with the previous two bullets, is that we will look at the revenue and look at the revenue and expense projections and then come up with a risk plan as needed to turn into the department to cover any potential losses that are identified there. So as it relates to funding methodology, so as you're aware that I've talked about before and other people have done presentations on, we are implementing new funding structure for specialized residential services starting October 1st. So that will be rolled out. We are in the process of sharing all of that information with each individual provider at the person served level. So we'll be working out that and monitoring how that goes the first fiscal year of any new methodologies. We keep a pretty close eye on how they're doing revenue and expense wise, just because it is new. In addition to that, as I mentioned before, we'll be working on the service model for substance use disorders and actually plan to work on that during our retreat up north with substance use providers. In addition to that, Diana will talk in a little more detail, but one of the items we want to work on a plan and rate structure for is utilizing technology to support staffing in unlicensed settings. So that is planned for this fiscal year as well. And finally, we need to continue to dig into hospitalization rates and expenses. We've seen that go up over the last couple of years. So we're working on identifying what those changes are and what, if any, impact we can have on those expenses. In addition to that, now that we have the methodology for licensed settings done, we want to work on unlicensed settings, which has proven to be far more complicated, I think, than we had hoped or planned. So we have to work out a new way to fund that and structure that funding because as with anything, we want to have logic and consistency in how those services are funded. And right now, with the variation in how people are served and the fluctuation in how they're served individually, that becomes very difficult when you're reporting on a per-day basis. So that's one of the goals for this year, is to make sure that we figure out how to fund that with structure and consistency across all providers.
To make a quick comment, just as we haven't gotten to it yet. We're going to talk about the dashboards, board access later, and I'm just wondering, because we're talking about, what dashboards we'd like to see. So it would be great if we could see, quarterly, perhaps, the dashboard for these things that you just discussed: the specialized residential services, the substance use disorder, the hospitalization trends, and the
Or we can make note of those and share those with you as they're developed. Funding advocacy is always on my list in the annual plan, just as a continued effort to work with MDHHS and anyone else that will listen to understand the need for the system and its needs from a revenue perspective, and how and when expenses change and how and when they can support that with their funding methodologies. That's it for me on budget and finance.
Are there any other questions for Anya on this section before we move on? Okay, thank you.
The next area is
I want to clear something up in my mind, and this should not be taken as concerns, and I replacing any reserves at all?
Fiscal year.
We haven't replaced them in the last, what, 2 years?
Fiscal year 20, when we get into the revenue projections, you'll see where we land, and we will potentially will be able to.
Do you have any idea as to how much?
Yep, all that details
Share
in.
it with us.
Well, so all that detail is, it will make more sense if I do it in a whole. So I could tell you the numbers and try to piecemeal it in here, but it'll make far more sense if I go over it in total.
Expense is killing me, but I can wait.
Okay.
There's a whole budget section to this annual plan.
Okay, I'm sorry for jumping ahead, but I'm being selfish. I want to satisfy myself on certain things. Because if we're not replacing reserves, we're burning cash. And at one of the meetings, and this is really for the board's information, was something to do with, we're saving money by paying off the loan on the building. Theoretically, money that we should be using to replace reserves. But apparently that's not happening. It's money to replace expenses. Did I say that right?
That money is used to offset the deficit we currently have, and that's really
What I
just.
just said.
Yep,
Yeah.
so that's what was explained at the study session, is that any excess expense that we don't have in this fiscal year goes to offsetting the deficit we currently have budgeted.
Correct. Exactly what I said in different words. So I want to understand, because eventually you run out of assets to sell, and you're relying on the state and the government to fund us out of issues. And we saw where that's getting us. So you agree that if we keep burning cash, not increasing reserves to the tune of what we're burning annually, wrong? We're heading in the wrong direction?
I'll just say, Sid, I know when we talked about this at the study session, I made it really clear that as the CEO, I have directed staff in collaboration with the board, and even the projection for this year was that we would be using reserves such that we didn't have to negatively impact, one, service authorizations to people served, but two, we made promises to our provider network with regard to provider payments. So I know we're going to dig a little deeper because you asked for projections, 2, 3, 5% projections. At that time, we didn't know what our revenue was. But we went into it eyes wide open that we were using reserves to not negatively impact services or provider rates. So as we were talking at the study session, we said, do we need to start impacting those things? Let's take a look at our spending. What do we need to cut ultimately? And it's tough conversations and tough decisions. Now, we got really good news today at 12:30 that implies that our deficit is going to be erased and that we will be coming in. But I did want to make it clear, it wasn't like we went to them with a hand open saying, save us. It was the state doing statistically sound, analytical analysis of the needs in our community. That is the reason we got a 5% increase. But we went into this year, when I got hired, it was all over the paper. We were projected $16 million deficit before I even got hired. We went into it approving an annual plan, approving a budget, approving projections, saying, we're going to do right by the people we serve, and we're going to use the reserves so that we don't negatively impact people while we get through this time of advocacy. Now, I know you're concerned about finance, and you always have been, and that's a very strong area for you. But really, I think we should be applauding the advocates that the state and the legislators are acknowledging an underfunding of our public system and have come through with an increase. Now, Anya's projections that she's going to share, are based on the work she's been doing all week to prepare on the financial status, and we just found out at 12:30 some updated information. But I just want to make sure it's clear that we all knew we were using reserves for this year. Like, nobody did anything in a back room. You know, there was nothing unplanned about this. And it looks like the state has acknowledged, good job, Oakland County, you did right by the people you served. Had we gone in slashing services, cutting rates, we would be now having to have a conversation about reversing all of that. So it's kind of it's a leadership decision, and I'm going to own it. If you feel like it was a bad decision, I personally will own it, because I said use the reserves, and I thought we were all on the same page.
I am not against funding our providers. This is about the people we serve, as far as I'm concerned,
I believe,
okay?
yes.
It took me years to get over profit, and substitute that for service. So we're on the same page there. To make sure that we have the funds going forward in 3, 4, 5 years down the road until we see what the heck's going to happen in order to serve the people we serve efficiently and properly funded. So we're on the same page there.
We did do those
And
projections you asked for, so Anya does have a whole projection presentation for you.
I want to get that out of the way because I'm on the same page on that. I'm not opposed to taking reserves and using it. That's what it's for. I'm opposed to taking reserves and not being able to replenish it.
Here, hopefully, we'll be able to move back in
And I
that
know-
direction.
And I know that this 49 million is not guaranteed. Okay? So there's nothing wrong with looking at downsides. And I'm the most pessimistic, I said that wrong. I'm the most optimistic person. I know. I'll hear it again.
For a
Don't
minute,
worry
I thought
about
you
it.
had my rose-colored glasses on over there, so I get
I'm
you.
the most optimistic person that you will know. Okay? And, but when it comes to people's lives, I tend to get a little overly concerned, and good for that. Okay? So, as I'm going along, and I appreciate that comeback.
We worked really hard this week. I mean, the study session was just on Thursday so I know this is the annual plan and budget, but like, there's an entire presentation on costs and projections, 3-year, the very things you've asked us for. I hope you're going to be impressed with the work we did to try and answer your questions. That would be my hope, so. And I don't know, I was happy with the good news today, because I think it's, okay, good. All right. And I do agree that we all want what's best for the people we serve. There's no doubt about that. Okay, thank you.
John Paul.
If I may, just touch a little bit on what Sid had indicated in the study session. And, I think the idea is that there's just a little discomfort with utilizing reserves with not replenishing it or, operating a budget by having to go into our reserves. It sounds like there was some good news today. So I'm really interested in hearing that. So as we get further along, maybe we'll get more answers and more questions. But I think at the end of the day, we all do respect that value of providing, the services to the community, the best services that we can provide. I think that's what we all got on this board for one reason or another. We all have a passion for this. It's just how we get there. We're going to have different viewpoints. But I support what Sid says to the effect that, I do have some discomfort about reserves, but we're going to get more information, so I'm interested in hearing that. Thank you.
We need to remember that we support people that have various diagnoses, including anxiety and other conditions. And if we go around all the time saying the sky is falling, we're doing a disservice to the very people we're trying to instill hope and optimism. And we got good news today, that next year is going to be better. And I just, at some point, we have to acknowledge that some of the very things we've been trying to advocate for, the news we got today said that we did a good job, so.
And I think that's a great thing, but we also have to be realistic. I mean, we all are optimistic, and I think we all bring that to the table, but we also have to be very realistic in our views. It's not fair not to be that way.
I agree with you.
I'd like to make one comment on that, too, because many of us around this table have worked inside this organization, and we do not take lightly the rebasing and the depletion of reserve funds, and that happened across the state. So there's Oakland County experience in the context of a larger experience. And many of us have painstakingly had conversations around the budget. And our job is to take a calculated risk. How do we continue to move this system forward for the quality outcomes for people's lives, make sure it's funded to the fullest extent possible with the money that we have locally? And it has not been easy. But let me tell you, again, the calculated risk that we took going into last year's annual plan, where this board approved a deficit budget. We walked into last year with a deficit budget. I'd like to remind people of that. And it was approved. So we knew this year was going to be very tough. And I would like to echo what Annette says. We can thank the advocacy folk, every person who sent an email and talked to a legislator who said, this system is underfunded. And that's the issue we had here. That's the issue across the state. You don't get at least 9 PIHPs who are in deficit because people are mismanaging funds. And quite frankly, our legislators were very tired of having to have the department go back for supplemental requests. They said, I think, get this right. And I think we're coming closer to where we need to be on a right-sized system, at least funding for where we are today. So I feel, as you can see, I feel very strongly about that. And Anya will talk more in terms of the projections and the good news that we did get today. I'm with everyone else. I think you'll see that it's not ideal, but I think there's plenty to be celebrated today. And with that, I'm going to move forward on health and wellness. This is care coordination. The first objective is, gives a nod to our ongoing participation with our PIHP contractual obligation in working with the Medicaid health plans on risk stratification and jointly providing care coordination to people. The second objective talks about collaborative efforts with Honored Community Health and the Oakland County Health Division. If you look at the draft plan, it delves more into data sharing with those organizations, and Diana will talk a little more about health information exchange and other data exchange for analytics, big data exchange. And then finally, if approved in the state budget, I think many of you know that as what we call an alternative to Section 298, Oakland County had the opportunity to advance some language. And if that budget is approved, I'm not sure, the latest breaking today, when I walked out of my house today, it said we were close to a budget. Hopefully, we've got one soon. We will be expanding risk stratification and care coordination with the Medicaid health plans to a larger number of people. So we look forward to that initiative. The next area is participating on a statewide level around emergency department and hospital visits. I would like to remind people here that across the state, Oakland County is known as having the lowest hospitalization rates, but we continue to work on that and divert people from hospitals as much as possible. We are involved in some statewide groups relative to psychiatric care, the number of beds, hospital beds available to people, in improving that work, not only in Oakland County, but across the state. Population health management has to do with our continued use of a tool called ProAct and the Care Connect 360 data, the claims data that the department allows us to have access to, and we use that to do population analytics. So we know then how to work to improve those HEDIS measures, or how to train staff, how to work with people to be more engaged in their own health care. And then finally, we have our own complex case management that we launched, and we're going to move forward with HEDIS measures around those initiatives. Finally, the last one in this area has to do with a behavioral health home. Many of you know that the department approached us to participate in a pilot project. We continue, which is very exciting. We continue to meet with their representative from the department, as well as another PIHP that is being looked at to participate as a behavioral health home. So we'll work with them to design it, and then we will identify at least one local key partner to help launch that. Are there any questions?
I have just one. Going back to care coordination, if the language does stay in the budget and we do embark on the pilot that we presented, does that result in shared savings between us and the Medicaid health plans?
That does not at this point in time, but that's a prelude to that.
All right, thank you.
We know that by working together, we do have better outcomes for people. There is a savings to our organization. There tends to be more of a savings to the Medicaid health plans by the work that we mutually do.
Quick question on the pilot, and I'm just trying to understand how the agency works. So I think it's wonderful, and we'll be working with the PHIP. When you do that, is there an RFP that goes out, or you know that there's a PHIP that's already interested, and we've been given the 500,000 is the understanding, OCHN, from the health?
You're talking about the behavioral health home?
Yeah.
Actually, there is $500,000 from the Health Endowment Fund that the department has received. So they will be working with us. We are one of the two. We are the PIHP that's been identified. There is another PIHP or another area. So there will be two identified, and we are one. Yes.
Oh, so it's very
that will,
exciting.
Yes.
Okay, thank you.
You're welcome.
Are there any other questions for Kathleen? I don't see any, Kathleen.
Okay, moving along to supports and services. The first area has to do with children, youth, and families, and we know that we want to develop incentives in the service models to improve outcomes. So those have not been identified yet, but we will continue to work on that this year. And we will also continue to implement the youth suicide prevention work plan that has been involved in accordance with the department and the Oakland County Health Division. I think many of you know that we had a 5-year grant. This is the last year of that grant. We worked with the Health Division in a collaborative before the grant, and we will continue to do that after. Juvenile justice initiatives will continue. We will expand the capacity of what is called rapid engagement and access to community health, or REACH, which is embedded with the Oakland County Jail, and that's to reduce recidivism or re-incarceration. And the next one has to do with a grant also to reach 50% of the public school students to make them aware of access to mental health and addressing their mental health needs.
Question about that. So increasing the access to the public school students, that's done in collaboration with the school districts, or how does?
Absolutely,
Okay.
yes.
So I'm just trying to think, because in my school district, we collaborate, and I just was wondering, then that's something that's being expanded more than within other school districts. I saw the news release that was attached in the email we got earlier this weekend.
Well, there's several initiatives that are happening. I know there's a large-scale initiative through Honor Community Health. They received a large grant to actually place services inside each of the public schools or the schools, which would include a counselor. We also have received a grant to, at a local level, participate with the schools to make mental health needs or awareness needs available, as well as access to services.
You say awareness needs, so that's not the identification of a need for mental health, but then.
Right, well, and we've had youth mental health first aid for quite some time in this county, and we have in-house trainers, and we work with the community collaborative around that.
The key is the identification part then with the students in the schools, and then from there, connecting them with services.
That is correct.
Okay, thank you.
We also have justice initiatives, as excuse me, that it did address that. Moving on, we will continue with the implementation of our crisis services. Many of you know last year was the launching of what is called Intensive Crisis Stabilization Services. That is a county-wide mobile team that's available to everybody and anybody in this county, whether one is receiving services through the public mental health system or not. We need to develop dashboards. There's some more dashboards for you to track data and trends. And we do actually have a growing number of families who are accessing mobile crisis services. Culturally competent services, we have a military and veterans, strategic plan, and we have a 5-year cultural competency work plan. Many of you know, or some of you know, that Dr. Lawson has been invited to be part of the National Council Initiative around health disparities. She is, I think, wrapping up a 8-month work group and has traveled paid by the National Council to various places in this country and working with a cohort of about 30 people from across the country on plumbing the depths of biases, discrimination, and looking at data within our systems as well as our county to improve access to all people. This area is social determinants of health. Again, this addresses housing, employment, transportation. As in the past, we want to continue affordable subsidized housing for people. We work with Community Housing Network. We want to increase by 15, and this is scattered sites. It's not a lot of people living together. We have long been proponents of fewer people living together, people signing their own leases, owning their own homes. And we'll continue to work with Community Housing Network with the Oakland Housing Link website. We launched that last year, and we are now going to move into the second phase of not only identifying available housing, but also assisting people technologically to find roommates as well as housing. In employment, we're still going to focus on competitive integrated employment, and so we'll have data to take a look at that. I know there was a question on how do you measure this, so we do have data points that measure that. And one of the couple of exciting things that have happened around transportation are 2 grants that we received. One, we're participating with regional transport or on a federal transportation grant to look at transportation resources and barriers. Actually, we have a grant-funded staff who's located at this organization and is working with a number of organizations in our community and our region to identify barriers and make recommendations. And we also have our recipient of a department block grant, which reimburses mileage for rural transportation. Substance use prevention and treatment continues to be a focus. Many of you know that we are continually focusing on the opioid epidemic. So we have a fair number of grants. If you go to the grant section of the annual plan, you'll see a list of all the grants. We have a number of them coming in to address prevention and treatment relative to opioids, as I indicated. And I'm happy to say, I figured this out per our own medical examiner's office. The number of deaths in Oakland County because of opioids has decreased. So that's a good trending for us. And we want to implement requirements of substance use disorder, contractual requirements for people on probation or parole. Many of you have had already a prelude to working with the Department of Corrections. And rather than contracting directly with the Department of Corrections, the Department of Corrections is moving some funding and expectations through the department, and that will be in our PIHP contract. So we will do the same in working with the Department of Corrections, just not directly. Are there any questions in that section?
I was just wondering how you got to the objective for the housing of 15 per year. I mean, just seems like an unusual number, like if there was data, we haven't seen that.
There is data. The Community Housing Network certainly develops a number of projects throughout the year. In the past, they would come to us for funding. We had some residual funds from a bond. We purchased 18 group homes quite a number of years ago, 2006, the first year I arrived. And through that bond, we did not expend or use all the dollars. So we maintained that bond funding, and we had money then that Oakland, Community Housing Network would come to us and request funding to be able to use that money to leverage grants, money from MISHDA, to be able to do housing projects throughout Oakland County. And I know they did Unity Park, Unity Village.
Unity Park in Pontiac.
Yes, Unity Park in Pontiac. They just recently did a ribbon cutting in Oak Park. And it is housing projects that are for everybody, all people. And however, they have said to us that X number or a certain percentage of those housing units will be available to people we support, people with disabilities.
We know if there's like a wait list? I mean, are we finding that we?
There is always a wait list.
And how many people like are on
Oakland
this
County
wait list?
has a lack of affordable housing. And so I know that's a conversation we've had with the Health Division and others. When you look at social determinants of health, how do we work as a county together, not just this organization, but how do we leverage a different way of looking at housing development across this county so that all people of low income, and certainly people we support fit in that, but all people with low income have equal access to housing.
Is it possible to find out how, since we're funding them, this amount, how we are doing, like what percentage of people we are not housing that need the housing in this, that of our constituents or the people that we're helping, members in our
We can
community?
certainly do that. I know there's pent-up demand with our
Just wondering
budget
what
having
percentage.
gone in the opposite direction
Right,
we
right.
wanted. There have been a number of people who have been sort of on hold or in place, especially people living with family members. And we know that there's a number of people who'd like to move out and find roommates. So we can work on getting you some numbers there.
Great.
But
And
I
how they
think
got
those
to the
will
15.
continue to grow.
Great, thank you.
Jonathan?
I know we've had a lot of, the focus is always on continuous improvement, and last year we offered some number of incentives for providers. And I wondered, I know we're going to add more. You mentioned that we're going to try to create some new ones for this year, pilot them and prototype them and whatnot. I was wondering if it's a way to produce a list of what measures we do, what measures and incentive plans we do have that are in place, and which ones we plan to do for this coming year in detail.
Yes, that should be fairly easy to get. We have been meeting with the providers and going through the incentives for this next fiscal year. So I think we're just about wrapped up, aren't we? almost wrapped up. Anya, one more meeting? And
And I did send you the list of the different models that we have, but it didn't include the ones we're hoping to roll out. In each one of those models, that's why we did have like Dr. Nicole Lawson come, because each one you saw is pretty detailed as far as sometimes it's rate structure, sometimes it's incentives at the end of the year based on data. So we can get you an updated list with our projected ones we're working on, and then we're going to continue to have presentations so you guys can get more deep into each one, because each one has its own complexities and stuff.
Bring it up is because I'm trying to make sure that we maintain this transparency. That it's there, that it's publicly accessible, so that people see what we're doing to help promote this area. Okay?
And certainly those incentives are stretch goals, as we call it, stretch incentives. As Annette indicated, there's certain in-service models, there's a certain expectation of outcomes for people, and these are to stretch. Okay,
Before you go on, Bajaya, did you have a question? Okay, well, I did have one about culturally competent services. I know that we've had some staff changing around the group that was working on that 5-year plan. Is there a plan to bring an updated version now that you have other people in place that are leading that charge?
yes, Ken. You mean bring it back to the board?
Bring it
for
back to the board
current
and let us
discussion,
know where
yes.
we are with that.
Absolutely.
Thank you. Putting you on the spot.
You're welcome.
Write it down.
Thank you. Thank you.
You're welcome. The final area is technology and innovation, and Diane is going to talk about this area.
Good afternoon. One of the things that has really, as you've heard a lot as we went through the presentation today of the annual plan, is dashboards and data. And it's been something that our organization has really relied heavily upon for the last several years, well before my time here. But one of the things that I wanted to do when I arrived is look at, are we using the right tool for our organization? And we're using one that doesn't really fit our needs anymore. And so there's been a lot of new products in this particular dashboarding, and we call it business intelligence or data visualization. Take your pick of the words. We've seen a lot of products come to market. So what we did is we did some evaluation, and we have decided that we're going to move to what's called Power BI. And our goal around this one is to migrate at least 50% of our dashboards and analytics to Power BI by next September. This next one we're really excited about, and it is partnering with providers to look at technology that can supplement direct support professionals. You know, as we know that there is a shortage, and as well as we're also looking at how can we provide people to be able to have independence. So if someone says, I would like to be at home at night, I don't want to have anybody in the home with me, and how can we look at and figure out what would make that possible for the person? So there's a lot of options that are available, and what we will do is start to work with providers to find the right solution for people. The next one is health information exchange, and this is another area where we've really seen a lot of work in the last few years, not just from OCHN, but around the country. You know, for a long time we've been hearing about we'd be able to take our electronic medical information on a key fob, or I don't know, and a chip in our hand, who knows? You know, we've been hearing lots of things for a long time. And we're still not quite there yet. However, we are continuing to push the needle in OCHN in trying to make this happen, because we believe that data sharing is really important for the coordination of care. So our first goal, objective, is to partner with Honor Community Health to receive lab medication and data for the people served by both OCHN and Honor. We have been meeting with them for the past year and talking about what the possibilities were, and this is a great starting point since we have about 40% of people served are by both them and us. The next one is MyHIN, which is one of the health information exchanges in the state of Michigan. Currently, we receive ADTs, which stands for admission, discharges, and transfers. So when someone goes into the hospital, let's say Beaumont, we happen to receive what's called an ADT or an admission, letting us know that the person went into the hospital. Behavioral health has historically not participated in sending data to any of the, I'm going to call them the HIEs or MyHIN, at all due to privacy concerns. But there was a change to the mental health code 2 years ago that actually is helping to facilitate this. So for us, we are going to be submitting our tentative go-live date, but we have the goal and the plan is by the end of the year to submit ADTs, so it would actually be admissions and discharges to any of our core providers, to MyHIM. The exceptions would be anybody receiving SUD services or is in the jail, so that, let's say someone lands in Beaumont, that they would actually know that the person is being seen at Easter Steel, CNS Care, so on and so forth.
On these, Diana, can we flip back to that other slide? Okay, so with the sharing with honor, is that going to be through MyHIN or is that going to be a direct point-to-point?
That's a great question. For now, it's just going to be a direct point-to-point. Because that way we can, that way we can actually look at potentially doing some SUD data, or not. We still have to work through that, but we seem that this is just going to be the fastest way for us to be able to get this really important data.
Can be another update to our PCE software, or is this something that we're doing outside of the PCE stuff?
The plan is for it to be, so PCE is also involved with this, yep.
The budget narrative has been updated for fiscal year 20. I won't read that to you, but the detail is in your actual draft annual plan. And then assuming people don't have additional questions, we can move on to the actual budget discussion, which will include and go over several of the questions that have been brought up.
Any questions before we move on? We can move on.
Part of in preparation for the annual plan, so what you will be asked to approve next week will actually be the annual plan and budget, which the format's a little different right now, just because what we talked about last week at the study session was, at the time not having actual rates from the department, that we would give you projections based on a 2%, 3%, and a 5% increase. So based on the information we had at the time, we were expecting an increase, we just didn't know how much. So as Annette had mentioned, we had a conference call today that gave us a little more information so we can focus a little more strictly on the 5% line than any of the lower amounts. But we wanted to do just a little bit of background information first for some of the new board members who have not seen some of the previous documentation. And that was related to the 3-year projection that we had done I think it was the end of last fiscal year, so I think it was the end of fiscal year 18 we did it. So we pulled together fiscal year 18 revenue and expenses, projected fiscal year 19, and then projected fiscal year 20. So what we have seen in the last few fiscal years, and for those of you who haven't been here, we've had a significant decrease in Medicaid revenue. Prior to that, we had about a $30 million decrease to general fund revenue. And then the change in the demographic of the people we serve has increased in the needs of the individuals as they age and the complexity of the services they're receiving. So all of those things combined have created the shortfalls that we've talked about at most of the board meetings. So we did a planful use of reserves in fiscal year 18 and a planful use of reserves in fiscal year 19. So as mentioned, in fiscal year 20, the department is moving away from the historical funding methodology. And as much as I'd like to make that simple, as Annette mentioned, the rate certification letters were 200 pages long. So the gist of it is, as much as I can simplify it, is we get paid for Medicaid eligibles. We get paid for the number of people in Oakland County who are eligible for Medicaid. Part of the new change in how that is done is we're paid a different rate based on whether they are enrolled in a Medicaid health plan or not. So the rates vary based on enrollment. In addition to that, we are paid differently based on age, gender, and I'm going to call it diagnosis, but there's more to it than just diagnosis now. They've added factors of, they look at prescription drugs now. They look at any physical diagnoses and things like that to try to better, the goal is to predict cost. So the idea is that they will use those things to better predict costs, because what they saw was that the last time they did this, which is when we lost about $30 million, it didn't do a good job of projecting cost where it was needed, in addition to the fact that we were losing money because we had people shifting over to Healthy Michigan. So this methodology, from my perspective, is a much better approach at trying to understand the differences in population served across the state, and also does a better job of saying, these are the changes that are happening in the industry. Again, with how we are funded, when we're in a situation like what we're in, with the economy being as good as it is, there are less people eligible for Medicaid, which means our revenue goes down, but the population we serve doesn't necessarily change. In fact, we struggle to get people to take jobs in direct care professional roles and things like that because they can go elsewhere because the unemployment rate is as low as it is. All of that being said, what we did with projecting revenue was trying to take a look at the different fund sources, and just a general overview of fund sources is Medicaid is our most restrictive fund sources. There are pages and pages of bells, whistles, and everything else that we have to deal with related to Medicaid. There are also a ton of reporting requirements, and that's our primary fund source. So we're about 90% Medicaid at this point between Medicaid and Healthy Michigan, which are interchangeable for the most part. Our next fund source is general fund, which is less restricted but does still have some requirements on it. And then we have the local dollars from the county, which is significantly more flexible than any of the other fund sources. Block grant is another fund source that is from the state, but it's specific for substance use disorders. It's the equivalent of general funds, but for substance use disorders. And then PA2 funding is specific to Oakland County. It's like local funding that we get from the county, but it's actually from a convention and liquor tax. So there are some restrictions. However, it's far more flexible than, say, a Medicaid fund source. So as I mentioned, we have a lot of regulatory reporting. There are a lot of limitations to how and when and what we can use revenue for. And you'll see when we look at things like fund source revenue and expense, it gives you a very different picture than just overall revenue and expense. So what we do at the year-end process that we go through is allocating all expenses to the appropriate fund source and what's allowable to be used for each fund source.
So that was a really good synopsis of what's going on with healthy economy, numbers of people under Medicaid going down across the state when things are good, a delay when things are bad because there's at least a year before they're eligible. So I know we've used some folks under contract from the state to help make sure some of our folks are enrolled in the right Medicaid programs. Okay, and that helps a small number of the people that live in our, but the bulk of the people that live in our county are not people we serve. So, so that leaves two organizations or types of organizations that also have a bone in this, if you will, in this fight. One are the hospitals that on occasion actually step up and help make sure that the folks that don't have Medicaid or are in GAP get enrolled and registered. And I don't know what kind of relationship we have with their business offices to make sure they do a better job of that and get them not just in Medicaid, but in the right Medicaid program so that we get higher revenues, if you will. And then the second is the actual managed care, the MCOs, so the Molinas and Meridians and stuff. And they also have the same situation because they want to auto with their HEDIS, NCQA, and HEDIS measures. They want to get the most auto enrollments, but also if they're enrolled in the right plans, then they get a higher per member per month revenue for their folks. So I have to believe, in fact, I know from my experience, that they've also got some people that are actively helping people that are quote-unquote uninsured to be insured in the right plans. Are we looking at, so my question is, are we looking at actively collaborating with both of those groups to see if a better job can be done for getting Medicaid enrollees enrolled and in the right programs?
A couple of things to that. So we pay for what we call MARA workers. And so we have those co-located within core provider agencies, and their job is essentially to process Medicaid applications. So the unfortunate part about how the DHS works in Medicaid applications is that a new Medicaid application has to go to the central repository and then is distributed. We can't direct it to the individuals we fund. What the MARA workers that we have do is process spend downs and things like that. So we have those. The other thing we've done this fiscal year, going into next fiscal year, is we put an incentive in provider contracts to get people moved from Healthy Michigan to Medicaid. So we're really helping focus on that shift for people that really shouldn't have been on Healthy Michigan to begin with, but there's presumptive eligibility that comes into play, and it's just easier because of the lack of documentation necessary for Healthy Michigan. So we've done a couple of things to try to put that in place. The other thing with hospital contracts, they are contractually required to do the Medicaid application. So we don't pay the bills unless we can see that they've done that.
Right, but I mean collaborate with them, just in general, about them doing a better job from their business offices to do that and get them into DAB versus TANF. Yeah.
That's a really valid point, and Christine and I just had a meeting in Lansing talking about what could we do with hospital collaboration. Particularly, the meeting was about the high-intensity needs people who spend too much time in emergency rooms. But we are scheduling a meeting with the Hospital Association liaison representing hospitals, and by all means, it would be in all of our best interests to focus on not only getting them Medicaid eligible, but we know Healthy Michigan is easy and quick, getting them DAB eligible. So we can add that to our agenda for the upcoming meeting we have with them.
Makes sense because they have a lot of uninsured, so they have a lot of self-pay, which would normally fall under Medicaid if done right. And then you also have Molina's being our biggest MCO here. But it's getting them to see if they can help make sure there's not interruptions, because that helps them and the hospitals. It helps both of those groups even more so than it helps us.
Right. So all of that being said, this is the 3-year revenue projection we did at the end of fiscal year 18. What you can see is this is the Medicaid projection. Up front there, or up to the top there, you can see we ended fiscal year 18 with about $270 million in Medicaid revenue. And fiscal year 19 included direct care wage projections and a couple of other adjustments, including those above there. So those are that's that supplemental we got there at the end of fiscal year 18. Included a DAB adjustment, which is people that were migrating off of the higher paying fund source and moving down to Healthy Michigan. So the state did do a supplemental for that. There was an increase to autism revenue and an increase to Healthy Michigan. So we ended the year at 270. Fiscal year 19 was projected to be at about 284. I believe what I just looked at today with the supplemental, we're expecting we should land at about 286. So we weren't far off. And then what we had projected originally for fiscal year 20 was about 286. So the fiscal year 21, we will start from scratch now because the methodology has changed enough that this makes this no longer relevant, which is why we haven't yet done a new 3-year projection, because knowing the methodology has changed, it would be pointless to do this at this point. However, the fiscal year 19 one is fairly accurate related to the amount of revenue we are about to land with after the supplemental. So you can see, general fund doesn't change much. The only thing that we are seeing in fiscal year 20 for general fund is, if you remember, there was that reallocation of the methodology for general fund that last year the legislature held us harmless, the $500,000. As far as I know, fiscal year 20, that will not happen, so we will be on the second iteration of that, which is a reduction in general fund of $1 million, and we will continue to see $500,000 increments of that until we get to the full $2.5 million. Otherwise, the other fund sources are fairly consistent. County match doesn't change, that's been 9.6 for a long time. All of these other ones don't change, other than things like revenue from grants. Depending on the grants, those do change. So those can fluctuate just based on whatever grants we get. The other one I want to point out is tenant income. Fiscal year 19 was projected at 261, and then fiscal year 20 at 894. So 894 is really considered full occupancy. But I will also say that was full occupancy based on a lower rate than what we will be proposing to anyone outside of the network. So building questions at some point, but we will end up in fiscal year 19 currently with 2 planned tenants, with obviously the work continuing on more, but any tenant that is not within our network would get a different rate than what we are giving within the network. So you can see the total revenue for fiscal year 19 here is projected at $322 million, which is roughly right where we should land, within a couple of $1 million. As it relates to expenses, same setup, same format. You can see some of the things that were adjusted in fiscal year planning for fiscal year 19 and then fiscal year 20. As I mentioned, fiscal year 20 will start from scratch again, just because what we have now, what we did with expenses, which we've had done for a month or two now, is we really had a lot more data related to the service models to really look at month by month what's going on service model wise, and are better able to project expenses relating to trends with service models and some of the things we're seeing with any savings, or, for example, the increase in autism services. So we've seen a material increase in autism services over this fiscal year, which is a good thing because we've had people waiting to get into services. So that's happening now, and so therefore you will see the expense go up. But we'll update this for fiscal year 20 with the annual budget that will be done for next week. So now that we have what we are considering draft rates for fiscal year 20, we will be able to finalize this. But based on our discussion last week at the study session, what we did was do the projections that were requested. So what we had talked a little bit about is that at the time we didn't have any rates at all. So we knew we were getting an increase. We didn't know how much. So what we discussed was, for this presentation, was to give you some options based on 2%, 3%, and 5% increases, and then knowing that you have to approve a budget next week, we will have to pick one, knowing that. But at this point, we have a pretty good idea that the 5% should be pretty solid, so we can focus a little more on that. Unless you want to talk about the other ones, that would be up to you.
The state hasn't approved their budget yet, so this is just the money they think they'll pay us.
Yes, everything is always predicated on the fact that the state has to have a budget and that they have to approve it, but my understanding, same as Kathleen had heard, is that we're really close at this point, and the whole road funding thing is being taken off the table for the moment. So hopefully we will get an answer soon.
Yeah, the same thing I read in the Detroit News today, that the roads situation has been taken off the table. I just texted my friend in the legislature, texted me back, said, still no approved budget. There's going to be committee meetings this week. So how sure are we of that 5% to move forward with it? I mean, what's the, how much confidence do we have in that?
So based on the meeting we had today and the fact that I have draft letters, I'm pretty confident in the 5%. We had a couple of other conversations that could potentially be higher than 5%, but 5% is what I'm comfortable with at this point, because it is new methodology and we don't have all of the detail yet. We would always understate before we would overstate it. So 5% is a good starting point for us to start watching the numbers come in.
Can't hear you.
Out of the budget for 2019, how much of the money of everything that we got from the state did we have to give back to them? Did we have to give back anything? Did we spend everything? It's the
So
end of the year.
that will all be firmed up during our year-end processes. So if you understand, our fiscal year goes for another month yet, so we have the end of this fiscal year. So we won't actually start to look at year-end until probably November, when all of the providers have had time to get all of their invoices in. They report that information to us. So really, their hard cutoff is not until late November, to where we actually understand everything that they spent, everything that we're going to cover, and we start to look at that. Typically, we don't send money back, other than in particular grant circumstances where we can't spend the money because of the restrictions on the grant, but that's few and far between. So I'm going to, unless people want to do otherwise, I'm going to focus on the 5%, just given the information we have. So what we did here was take where we were at for Budget Amendment 1 for fiscal year 19. What I did with fiscal year 19 was put a projected amount for the supplemental that we're expecting. So in fiscal year 18, the supplemental was $60 million, and we got $6 million of that. So if the supplemental is $50 million, I'm expecting us to get 5 of that. So those are just very rough numbers, not based on anything they've given us at this point, but I had to pick a number. So what you see there in the fiscal year 19 with June financials column is basically me taking the June financials from a revenue perspective, adding the $5 million in the supplemental and annualizing that for the remainder of the fiscal year. So it's 3 quarters of actuals, annualized for the fourth quarter, plus the $5 million in supplemental.
The 5 million in supplementals, again, just getting back to the idea of, you said year previous, it was 6 million or 60 million, you went with 6. This year, 50 million, you're going with 5. So and that you feel that that's a solid number to go with, a safe number to go
Yeah,
with.
as much as I can at this point, yeah. Typically, we're roughly 10% of the distribution, so that's why I would go with that amount.
Oh, it's kind of a more conservative number than you're going with.
I always will lean on the conservative end of revenue projections, and same with expenses. I would lean on the conservative end and project more expense than I would expect. Yep.
My question is tied to one. I've asked this to you, Kathleen, in the past. It has to do with that Court of State Prisons grant that's part this year. Is that reflective in this, or is that still TBD? I thought there was some sort of statewide.
MDOC, is that what you're referring to?
Yes, MDOC.
And I'm not sure about these projections, but that money is part of this FY20 budget.
Well, then it's in the grants area then.
No.
So
No,
just
it
to
isn't.
clarify, there is revenue in the new rates for MDOC services, and that's Michigan Department of Corrections. We don't yet know actually any of the detail around that, but they did put the money in there, but my projections are totally outside of that. And that's why I say these are conservative. Until we start to see numbers come in and I have the actual detail to be able to cell by cell do it, this is kind of the easy way to do it.
I think it's a cool initiative because we're doing something, again, beyond what we normally do. So we're spreading our wings.
Right, and let me just clarify it. It is not a grant. Now that the money is going through the Department of Health and Human Services, it becomes part of our prepaid inpatient health plan budget.
So it actually will come in with the Medicaid capitation. So from my perspective, it's part of our Medicaid revenue now. They didn't separate it out, which I thought was odd because I thought it was a different fund source entirely, but for whatever reason, they've included it.
And I have a strange question. What happens if a PIHP comes with a great idea of, and in this somehow will have need for new Medicaid sources? How do you handle new programming? Like, what happens then? Like, do you then have to do an RFP, or what if someone comes up with like a wonderful idea?
I guess, say that's the beauty of managed care, that we get given a pot of money for the most part, other than the grants. Like Anya said, there's really no flexibility with the grants, but the pot of money we get It's up to us to incorporate any innovation, new ideas using the resources we have. So unless we can apply for foundation-type grants or something outside the box, typically we just have to use the given resource we have as a PIHP. So like I think of, we're trying to pilot using technology as an alternative to help with the staff shortage. There's nobody going to be handing us a bunch more money to do that. We are going to have to try and balance the fact that maybe the use of technology could lessen the need to have face-to-face contact for individuals, let's say like while they're sleeping at night, give people more independence, less reliance on staff. Hopefully, some savings can be achieved to cover the cost of purchasing the technology. But they don't tend to give us pots of money for good ideas. It's just inherent in the PIHP to use the
Like
resources.
Medicaid service that someone could use. If it's a new service but that's covered by Medicaid, can you accept it, or it's just like any new idea you don't accept because you already spent the funds? That's where I'm.
So the Medicaid manual is really dictating what we can provide under Medicaid. So the state sets statewide guidelines regarding what the services are, how the services are used. This year, we have a new Medicaid service we have not had before, and it's called Overnight Health and Safety Monitoring. Never had that code before. It'll be something new we'll be rolling out. We've asked a lot of questions, like one, does that mean face-to-face awake staff, or could it be used for more flexible options? They're still defining the parameters. So we have members that are on the work group, but it's rare to get a new Medicaid service introduced, but there is one that just came up this year, and it's in our new rate setting, so they're expecting to see some new utilization of a code that's never been used before.
Say, what you're talking about, like we have a new idea and we're going to get money, that's fee for service. The P in PIHP is prepaid. We don't get fee for service for most of what we do, outside of very few things, so.
Looking back at this 3-year revenue projection, the investment from the accountants.
No, that was the death adjustment, because, so what happens when we get paid the capitation amount for each individual eligible, the state is supposed to monthly go back and take back for anyone who's passed away. So they hadn't been doing that for about 2 years. And so they surprised us with a death recoupment of $2.1 million. Yep.
Every capital improvement fund there is, how much is in there?
So that's the third part of this presentation. So it's built into our administrative budget, and I have the detail to go through with you after we get through this. Capital improvement is budgeted in our facilities budget, which is in administration, and I have the detail. It's in your packet. It's the last section.
In segregated funds?
So going back to the five, sorry, what?
You sure you can wait, see? I'm not so sure you can wait.
All the time.
You're chomping at the bit.
I don't have to be in here
Can't she
until
just
5
get
o'clock
to
in the
that
morning,
part?
so
Can
don't
she?
worry.
But some of us don't have the luxury that you have. You keep saying you can wait, and then you don't wait.
I'm patient, aren't I?
No, you're not patient. You're not patient.
Malchiah, how long did it take you to think about that?
Not long this time. Because you said you could wait at least 5 or 6 times during the course of this, but
Hey, I'm
that's
so-
just me.
I'm so young, I could wait forever. Don't worry about it.
Okay, you can wait.
Going back to the fiscal year 25% projection. So that, we're looking at roughly almost $302 million in Medicaid revenue. Again, that is conservative. Until we start to see numbers come in and I have more detail, that's what we as a leadership team have agreed was an appropriate amount to put in the budget. That also includes that $5 million supplemental and then adds that 5% onto that. The funds you see below the Medicaid line are things that don't change materially other than the general fund line, which you see if you look at the BA1 fiscal year 19 column, it was at 12.7, now it's at 11.7. That's that $1 million that's redistributing the general fund dollars across the state. So this is our second iteration, so it's a $1 million reduction. But as you can see, the other amounts don't change materially, other than the grants went down a little, and there's a couple of grants that were just ending in fiscal year 19. And then tenant income, we adjusted to be more at reality for what we're planning at this point with the 2 tenants we currently have signed. I do have another proposal in my inbox for another tenant that is interested in the first floor space. Haven't looked at that yet because we've been focusing on this, but we do have additional interest in the first floor space at this point. So that gets us to total revenue of $330, almost $9 million. Any questions on revenue before I move to expenses? When we get down to expenses, you'll see the net result. Okay, so it's on the next slide. Oh, okay. So moving on to the projection of expenses. So moving on to expenses, you can see system administration. What you do see added there is the beginning amortization of the parking lot repairs and resurfacing. So we do have a better estimate on the cost at this point. It's roughly $750,000, and we're hoping to be able to do that in the spring. Unfortunately, we can't get it in before the frost laws start, so it's going to have to be spring before that happens. As I mentioned with related provider expenses, what we did was take group by group on the service models and really look at utilization that we've seen over the last fiscal year to do a more detailed projection on expenses. And you do see some that have gone up from fiscal year 19. I'm going to use, I thought it was, bear with me a second. For provider adults, you can see the expectation is that expense does go up slightly. Core provider kids actually goes down, and that's what that has to do with is the implementation of service models, and so now the rates are consistent for both providers. So that does have an impact on the expense. So that detail was all worked out. We've had that done for a little while. Claims and use tax is specifically related to the amount of tax we pay on Medicaid revenue. So that fluctuates just based on the amount of Medicaid revenue we get in. Local match drawdown expense, that's the one we've talked about where we are required to send the state roughly $2.4 million in local money so they can draw down additional Medicaid money, and there is an initiative to try to remove that so that we could keep that money. As of right now, that's not been removed from our contract. You can see the board designated what says Owen and actually should be honor is continued into fiscal year 20. And then vocational, you can see we did project that to go up a bit because as we get people employed, the expectation is that those expenses will go up slightly. In addition to that, you can see the residential line drops minimally, but it does drop slightly, and that's related to the implementation of the new rate structure for providers. So that gets us to total expenses if we are utilizing the 5% at $335 million. If we use the 5%, that gives us a almost $7 million surplus in total. Now remember, the surplus in total is different than revenue expense by fund source. So what that shows is still a slight Medicaid deficit, but in total, it's still a surplus. I realize that's fairly confusing. Differently, let me know. Like we have a total net deficit of $13 million in fiscal year 19. The total net profit would be $3.87 million in fiscal year 20 using 5%.
Just trying to understand. So I know it was stated earlier about 90% of our funds is Medicaid, correct? So if would be at a surplus of the 3.6 million, you said the Medicaid would be at a deficit. What's that number again? Did you say that number?
I do that up
Okay.
here. So much of it depends on the split between who we're serving. So that's something we assign fund sources like that at year end typically. We take historical splits in the beginning of the fiscal year to kind of estimate the way that will play out. But at year end, it really depends on who was Medicaid eligible the month they were served and who wasn't. So it's really a person by person assignment of where that expense lands from a fund source perspective.
We don't have any projections on that.
I didn't do that for this presentation. Yes, we have an overall split that we typically use, but I did not bring that for this presentation.
I get that at some point.
We'll do, for the presentation for next week, now that we're going to land on the 5%, we can do the revenue and expense by fund source specifically, yes.
In the mic, please.
Get a tenant for this building, and then you have under revenues, your tenant income of about 121,000. Where's your expense if they do a build out?
So that would be built into their rental amount. So the build-out expense would be built in and amortized over the length of their lease. So we would pay the cash up front and then amortize it over the length of the
No,
lease.
but where is it under what line item in expenses?
So it would fall under building expenses if that were to happen. So that would have to be adjusted
Where is there a building expense line item?
in our administration.
It is, okay, so maybe we could have, just because we keep talking about that, maybe we can have a line item, possibly?
Separate.
Because the building is so important. I mean, we have a parking lot line item for capital needs. Why not have a separate building line item?
We can give you that detail. We don't typically put that in our budget in that level of detail.
Oh, not
This
in the
was-
budget, in general, just in general.
This was really for illustration
Yeah.
purposes. It wasn't intended to be in the actual budget like that. I wouldn't list that.
In our normal budget and our monthly budget isn't in there?
Not specific like that, no. Typically, we do everything rolled up because it does go out to the public. We don't typically list those things. We can give you that detail on a regular basis if you'd like it. We just don't present it in our finalized budget.
Just because you had the tenant income in there, so that's what made me think of it.
Just the hot topics that come up are the ones I try to add.
I got it. Okay, and then my other question is, you talked about the PA2 convention and liquor tax, and then I know that's going back to revenues. Where is that? What line item is it in?
From an expense perspective?
Both.
From an expense perspective, it hits substance use expenses. So that would fall into, okay. And then from a revenue perspective, it's in there specifically as SUD other is where that falls.
Thank you.
Are we at the risk of that going away or getting reduced?
PA2, not to my knowledge. PA2, not to my knowledge. It's actually increased with the paying off of the Cobo Hall. As long as people buy liquor and tobacco and things, it seems to go up.
I thought it was going to go away because Joe Louis is not, is being.
It was related specifically to Cobo, not to any other convention facility, to my knowledge.
Can you wait, see it?
I have a question, if I may.
John Paul.
Just going back, I know we had established a 5%, but just in line with that vision of being, having this realistic viewpoint, I just want to make sure I understand it correctly. So we have a 2% and a 3%. So if we're at 3%, we're still in surplus. Is that correct, or am I?
No, if you look down the change in net assets, if it's at 3%, it's a negative 2 million.
Okay, so then that's negative. Okay, that makes sense. Thank you.
5% would get us out of a deficit overarching budget,
I
yes.
get it. Thank you.
Plan would be to update this for next week so that the actual budget document that would be included in the annual plan would be with the 5%. And then we would monitor that going into fiscal year 20 and adjust with an amendment as soon as we get a decent sense of what's going on with revenue. As I mentioned, I do think this is a bit conservative.
Any other question? John Paul?
I just with regard to the Medicaid, though, we would have that information then. And we could get that before, because I'd like to just have it before, just so I could compare.
We will do, typically what we do when we do a normal annual plan is you would get the budget document that looks like this with just one column, but then I also do a fund source chart that tells you fund source specifically, revenue and expense for the ones that can be commingled and the ones that cannot. So you'll see it a little more clearer from a total net position perspective and then by fund source. Yep.
Are there any other questions for Anya? Okay, you can continue on.
Long-awaited building conversation. Am I doing all of this? I'm going to give you some of the history on some of this.
We're going to play tag team today, which is how we planned it and collaboratively in presenting to the board, working from the study session. So one of the things we talked about in regard to the building, especially for our new board members, is understanding one of the key elements that brought us here. We were mandated by the state to reduce our administrative levels by 5%. So this is an image we created probably 6 years ago, a diagram of what our infrastructure of our system looked like. And the lines and the arrows in between from the CPAs, which are core provider agencies, to our direct service providers, really symbolize those administrative functions that were delegated in the past. This was the model that we aspired to achieve. We did rotate it entirely to put the people at the top, and not just that we were removing administrative layers, but by doing so, we were bringing ourselves closer to the people we serve, which would gave us an additional opportunity to hear from them, to get their input, and to be closer in touch with our community needs. But again, this model was designed with the mandate by MDHHS to reduce our administrative layers.
Question for you. So I know we brought a lot of stuff in-house to handle so less delegated administrative functions. Do we still have a delegated entity where we have core providers managing the direct service providers, or is that all going away? I probably ask this every year.
So there's essentially very limited amounts of delegated administration going into fiscal year '20. Much of that was taking on the direct service contracts related to employment and residential and CLS. So there are minimal things still going on that are still a few things here and there, but the majority of it is now directly contracted with us.
Traffic is probably going away because core provider is just another direct provider?
So the idea is not to pay them to pay someone else. So if we're going to pay someone, we pay the provider that it stays with, and that's really what was the overarching goal. And for the most part, we are there.
The bottom line really represents care coordination as well. So there's still that relationship between all of the entities, and there really needs to be that partnership in order to serve people. These are the functions that were redelegated back to our network. I usually start, substance use began in 2014. That was one that the state passed a law that moved all of the substance use prevention and treatment to the PHPs. And then they're in alphabetical order in terms of those delegated functions that were reassigned to our organization. We tried to tie this information in with the org chart as well, just to make sure that the information wasn't taken out of context, especially for our newer board members. So prior to the move to this building, of course, with redelegating those positions back to our organizations, we were not creating new positions in the network. They were positions that existed. We had space for 104. We knew that that would not meet our needs as we strive to attain what the state was asking us for. Obviously, our commitment to community engagement, enhanced training was going to increase, and parking was an ongoing issue at all times.
So these are some of the things that really directed us to this building when we look at a historical perspective. Why did we need to move? Why did we end up here? And this just touches base on that 5% funding shift with the redelegated functions. Other things we talked about in regard to moving the building was an opportunity to become more person-focused because we could bring more people here. In doing so, we knew that we would strengthen our service delivery. And again, it gave us an opportunity to promote technology and advanced integrated healthcare. Some of the goals that we presented early on. All of this information was presented to the board at the time that we were buying the building and renovating the building. I just wanted to give some background to our new board members.
The building purchase expenses. The negotiated asking price for this building was 12.6. We negotiated the price to 10 million. The seller included some partial build-out items, which included the waterproofing, air quality testing. They also did mold sampling. They redid the roof and sealed the windows completely. OCHN build-out expense shows $2 million. In addition, the vendor resource build-out, which included the cafe, first floor, the boardroom, the wellness center, and the first floor conference rooms. The total projected price was $15.5 million, which the board approved an additional 1.5 for the Davis-Bacon Act for prevailing wages, and also for the first floor AC unit that was installed for circulating outside air in large meeting spaces.
I'm sorry, I heard the AC unit. I didn't hear the other two things.
The Davis-Bacon Act, which was prevailing wages, they projected or budgeted to pay certain wages, and based on this being a governmental entity, they were required to pay prevailing wages, which increased the labor cost of the project.
That rule has since been removed. We no longer have to do that, but that wasn't until after we renovated the building.
Just based on what he just said, I got to 15.5 plus 1.5 is higher than 16, so it's just a
So
little
the 15.5 includes the 1.5? It was originally 14.
Okay, where's the additional $500,000 go?
To that.
Oh,
Okay. Also, based on, the slogan that time costs is money, we thank the board for allowing us to go in and pushed us to get in the building by January of 2018, because what we, unbeknown to us, when we, from the time that we started construction, all the interest expense on the loan is capitalized into the building cost. So GAAP requirements require any interest expense on the loan is part of the building. So the longer that was a 9-month interest expense of $193,000. The longer we take to go into the building, the longer your building project is, the more the cost of the project. And so after 9 months of construction, we had to layer on an additional $193,000 for the interest expense for the loan. And then other things were, we had to do unexpected elevator repairs, and then also we added additional door openers throughout, automatic door openers throughout the building. And some of that came up to roughly the differences. Next slide talks about projected management, or projected maintenance and operational expense. Our operational expense averaged about $475,000. Snow removal, utilities is broken down by janitorial and all of the particulars that make up that $475,000. There were a few uncontrollable variables. We had an increase in the salt prices due to a shortage the last season. They layered on additional cost because there was a shortage of salt, projected high, about 7,000 higher than what we thought our original landscape would be. We also projected before we came into this building, we projected $400,000 worth of expenses. We went from a 2,200 square foot building to a 141,000 square foot building. So we did our best projection on operating expenses. There were a couple of things that added to our operational expense. HVA service contract agreement. We also had to do a few parking lot repairs, and then miscellaneous things, which were one-time things such as the pond, getting our pond up to it treated annually, which ran us about $3,000 for treatment. And we had to add an additional generator service agreement because we operate this building with 2 generators instead of 1. And we did a couple of miscellaneous things such as air quality testing requested by staff once we got in the building, and on-time landscape. But our general operating expenses run between taking away some of the miscellaneous one-time things, they're running about $450,000 a year. It includes utilities as well, water, gas, and electrical.
We have budgeted for 2020,
$450,000.
where we got a new HVAC system.
The renovation?
$1,000 for the new system.
So you're talking to me while she's asking. I can't like zero both things. So, so the new stuff was only on the first floor because this first floor was not this big open space. So this required new AC units because anytime you have a room that serves over 50 people, all those rules. So the upper one that serves all the other levels is not new.
And that's what we're paying.
Yes.
We have in our capital needs plan. I guess we're going to go through that, getting a new one up there and the cost of that later. Yeah, we have that in there. Okay.
Our HVAC service contract, we did do an RFP based on our RFP process, which has helped to keep our contracts in line with what is reasonable and and every time that we RFP, we get the best rate, the best, we compare different entities or vendors with one another, and we get the best possible contract. As a result of this RFP, we reduced our service charge from almost in half. So that 70,000 will go down to probably 45. So.
That answered your question. I'm not sure if you still had the question.
Next slide is a capital improvement. So we've listed several things that were added to our capital improvement. And capital improvement are items that increase the value of the property. It increases the value of the building. The personal assistance room was one item that we capitalized over 15 years, annual cost of $667. We're projecting a boiler for the entire building for $1 million, capitalized over 15 years. It's not to say that we need one right now, but the potential for us to have a replacement unit is there based on the age of this building. And also the parking lot lights, we're capitalizing, we're going to increase the switch to LED lights, and that's going to be roughly about a $15,000 capitalized investment, and we can expense that over, capitalize it over 7 years for $2,000 roughly $2,000 annually. And then Anya already mentioned the parking lot resurface and repairs, roughly a $750,000 capitalized project, and the life expectancy, it can be written off over a 15-year time for $50,000 annual cost. And then we were requested by the board to provide an awning, outside awning, and we capitalized that over a 7-year time frame for $2,142 over 7 years. So that was our capital improvement dollars of 1.70, roughly 1.8 million between all of the time useful lives was written off over 7 to 15 years.
And also that the HVAC that's on the first floor is new, the roof is new, the generators are new, and with the renovation, there are many things that would typically be on a list, but it's like buying a new house, you get a few years where you don't have to deal with a lot of that stuff. So we're dealing with the things now that haven't been dealt with or have come up since we've been here the last, what has it been, a year now? A year and a half? So it's, you know, some of those things have just come up over time that we didn't necessarily expect. We knew the parking lot would be needed at some point. Obviously, some of those other things were kind of just as we got here, we recognized things needed to be tweaked a little.
A quick question for you. Based on the list that you have here, which of these items are we going to do during this next? Replace the boiler? Are we going to do the lights? Are we going to do the parking lot? Are there other things that aren't on this list?
So the only thing that we would potentially not do this year, and Patrick can correct me if I'm wrong, would be the boiler. I think the boiler, we would wait until we have to. And then otherwise, all of those other items are being done in fiscal year 20. The boiler is kind of just preventative, putting that there just in case we have to, because it is original to this building. We don't know when, but we do have the service contract to cover us to some degree for some repairs and maintenance. But if they get to a point where they say it can't be fixed, which is possible at some point, we will have to replace it.
And is to the parking lot next spring?
In the spring, we just did the RFP, or we're in the process of the RFP, but they can't get it in this fall. They're booked out, so the spring will be the plan. So it will be in the budget, but until we have a contract to present to you, no, we don't have anything to give you yet.
Either of a bad movie we undertook, and but yet we undertook it, and I keep hearing the board approved, and I can almost vomit listening to that over and over again, because this board approved, for those that weren't here, this board approved numbers that we were given, and through no fault of the staff, they did what they were told to do. They did it at a risk. And in order for civility to exist, a lot of people were shunned and had no opportunity to really blast away. So I hope that we don't keep hearing the board approved. The board approved what we were told, and the numbers that we were given just didn't match up. And I can go over it with anybody that wants to see it. You're giving me every reason to say, hold on, where the heck is this money coming from? We talk in terms of depreciate over 15 years. We don't pay any taxes. What is depreciation? And I still don't understand how that saves us money. All we're doing
I need to jump in there. So depreciation is a required accounting practice that we are required to follow. It says that we cannot expense an entire parking lot in 1 year. Medicaid requires that. It's not about cost savings. It's a required accounting rule. So we're not making this up. This is all the rules that we're required to follow and our auditors expect it. It's not about saving money or anything else. We're required to depreciate things over the length of their life. That's standard practice in typical business. Any capital asset has to be depreciated over the length of the life of the asset. That's not anything different than anything we have always done. We did it at the old building, and we continue to do it at this building because it's required.
Generally
Hey,
accepted.
wait a second, excuse me.
principles.
Let me just get to your response. And I'm not going to debate you. I know what depreciation is. It's GAAP also. Do you know what GAAP is? General Accounting Principles. So I understand depreciation. Where is the money coming from? That's what I can't understand. This is fluff.
That's not accurate. This is not fluff. This is all built into our administrative budget. I can't make you help you understand how that works, but the reality is these expenses are built into our budget, and we're doing the best we can to try to explain that, but it's not fluff. These are actual numbers that are built into our budget.
Where is the capital improvement fund and how much is in there right now?
Built into the facilities budget that Patrick just reviewed with you.
How much is in there?
Well, for capital improvement,
That's what I'm talking about, capital improvement.
there's not a separate account
Why not?
for.
We have never had capital improvements separate from our
Then
building.
where's the money coming from?
It's built into our administrative budget.
I see that.
So you're asking me a question, but it's expense to Medicaid, just like our salaries. That's how it works.
We're going to take the Medicaid dollars.
That's how our administration is paid for.
Sid is finished, Hadass and John Paul. I see your hands.
The yield for right now.
Hadass.
So I wasn't here, when the building was built, and obviously there was a need, and you worked on it, and it's beautiful, and it's being used, and all the different agencies that use it. I see so many advantages going on. My background is, I do have a background in buildings, so maybe that's where I'm coming from with all the questions. I've also been on numerous boards where buildings are owned by agencies, so I just want to give you a little background of where I'm coming from. And in those boards, whether it's a governmental board or a quasi-governmental board or a nonprofit, there are subcommittees on the board that are involved so that you don't have your CFO and, I'm sorry, I don't know his title. I meant the gentleman. He's your controller. You don't have your accounting people responsible for a building and its complete maintenance, because that's a tremendous responsibility to put on two people. So what typically happens is you create a subcommittee, and on that subcommittee, some people on the board or on the subcommittee, not everybody's on it, you actually may have a builder in the community on the subcommittee, and they guide you and they give you guidance on things that happen so that as you move forward, it's very simple. It comes to the board, and there's an outline, and there's logic to, this is the reason we want to improve the boiler. This is what we need to do for, the reason I talked about the HVAC is because that's a big number. You have done the roof, the parking lot, but there are little things that can happen, carpeting. You can't have carpeting not be nice and smooth because someone can trip, or if there's insurance. So I feel, honestly, it's my fiduciary duty to make a motion that we can figure out when and how and everything later, that there should be a subcommittee for this building, of a building subcommittee. It can meet 3 times a year. And on that subcommittee, you have knowledgeable people who are used to working with buildings. You went from a 22,000 square foot to 141,000, that's what, 7 times larger building. There's just so many more responsibilities with that. And I just feel like as an organization, we're all very responsible, and we need to be responsible with this. Let's create a group of people who can just, make sure everything's moving smoothly, because the decision's been made, it's beautiful, let's use it, but let's take care of it, and let's do that logically. So if we can debate it or whatever, but that's what I'd like to put forth as a motion.
We don't normally accept motions in the committee of the whole.
I don't know really how this works, so you can decide.
Your idea is noted, and on behalf of the staff, we've said all along, if there's something the board's requesting different, we are open. So we're open to whatever the board decides would be helpful.
Yeah, potentially it's something we could revisit at the actual board meeting, because I do support that idea. And just going back to that $450 operation cost, do we know what the cost of operation was at the previous building, the Auburn Hills? We were at the Auburn Hills building when I left back in 2010, so I'm assuming we came from there to here, correct? Do we know what the operating cost was at that time?
About 130. It's about 100, about 130,000.
130,000. So that's a substantial increase. And, you know, I hear you, you know, going down the list of all the things and the cost and of what we're paying for this building, and it just comes to mind is it costs a lot of money to run a place like this. You know, it's expensive. You got a big house, you're paying a lot in gas, heat, and all the extras, and your roof, and all the other things that you have, which gets me to the thought that I came in when I first got back on the board was, you know, being in this big building and then having, just if I could double check this, I think it was 30, or about a third of the building is still vacant, is that correct?
Floor and part of the third floor, so that's probably about right. You thinking, Patrick's nodding? Yep, that seems about right.
About a third of the building, and I just, you know, just thinking back to what Sid was stating, the idea of that we're in this building, we have all this extra room, and now we're in the business of, you know, trying to find renters for the building. So you all good people are spending your time trying to find renters, people who will come in. And I just got to ask, you know, and I wasn't on the board when this happened, you know, at what point do we realize that, you know, maybe there's some decision or something we should look at, and possibly that comes from this committee, of alternatives? Is it the best practice to be in this building with this $450,000 operating cost and not just keep it simple into a smaller building as we were before at the $130,000 operating cost? Because like I said before, when I look back, you know, that's 7 times larger than the previous building was. And I think the idea was we were going to bring providers in here, and that we were going to rent space. But it sounds like, you know, how many years have you all been here?
Year and a half.
A year and a half. So in the year and a half, we're still a third vacant. So that's a whole lot of operating costs, a whole lot of costs that we're pouring into this building. And I come from been on my school board for 5 years, and we own a lot of properties. We sell properties. Sometimes we have to close schools when our foundation allowance goes down. Same situation. You have restricted monies that you can use. $200 million a year operation. We have grants. We have all types of different monies. But when you look at the buildings, there can be our most costly expenses: the roofs, the furnaces, the HVAC systems, all that stuff. So I just think it's something that we reflect on as a board. You know, and possibly that's something that we do in some type of committee approach, because as long as I'm on this board, as duly appointed by the Board of Commissioners, and we do represent the people of Oakland County, we have to make prudent decisions and try to do our best to add our points of view to right a ship when we see it going wrong. And in this instance, this building, to me, I'm not sold on the idea that it's necessarily, you know, the right move for us. Thank you.
Yeah, it's easy to be a Monday morning quarterback. I wasn't here either. I don't think any of our staff got into this business of mental health because we were interested in running a huge building. So I think it's a dialogue that can be had.
But I would like to answer some of that. Along with this presentation that we received today, we did not receive an update on the amount of money that we saved by not having to rent out facilities for training and other things. Is it possible for, I hate to add more to the staff, but if we're going to look at it, can we look at the full picture, because I feel like if it's a piece missing, people are making decisions or opinions based on not having all of the facts.
Some of that is in here, as Annette mentioned, we had 4 days, and this is what all of us worked on for 4 days, pulling this data together the entire week. So we actually were trying to do some high-level data grabs with the intent of doing deeper dives. I don't want to move anyone ahead unless we're ready, but to that point, okay, I do have some of that information. So we can go there and then go back to some of the questions if you would like. Clicker's back to me. This is like having the remote. Like I say, who's driving the car and with the remote?
Do you have another question, John
Hey,
Paul?
just another statement, if I may. So I just want to recognize the fact that I do respect the fact that you guys work so hard for this, and I do appreciate that, getting us this information. And I just want to ask questions as things go. I think that's important because, we essentially have to attach our name to this. We have to vote on these things. So I think as board members move through the thing, there's always the right time to ask the question, I mean, within reason, because we do have to understand this. But just so I could clarify, the $450,000 in operation cost or expenses, that does come from Medicaid dollars, is that correct?
Anything that's part of our administration, which this building is split between our fund sources proportionally. So if 90% of our fund source is Medicaid, 90% of the expenses are Medicaid, as allowable. There are some things that are not allowable, so those things would be removed before that happens.
Oh, okay. So
Our building is allowable
it
expense
is an
because our
allowable
staff
expense.
sit here, yes.
Okay. So I just wanted to clarify
Yep.
that. Thank you.
Some of this too, when we design it with the intent in our mind. What do we need to get through that the board asked for the meeting? What do we know that may be asked for that we can plan in the future for a deeper dive so that it doesn't become white noise in one meeting and that we forget what we talked about in 2 years. So we intentionally build these presentations with expectations that we may have to do a deeper dive at another point and give you what we can at that moment in time. So that's really how this presentation was built off the study session. I think we tried to identify what were the key issues we wanted to get through in this committee of the whole, but we all had expectations of what we may have to, when we have more time to look in and pull that information together and present.
Yeah.
So I want to thank you. I know it took you a long time to put this thing together. And I know that you've all worked hard. I hope you all know that our job is to ask questions. Don't take it personally. We have a right to. And for those that have been here for a while, I think you'll agree with me that had we had the opportunity to have more financial discussions in a civil manner, instead of being shunned around and shunned away, we would have been further ahead in some of these discussions. I'm very happy to hear that you came up with a suggestion, should have been had long ago. And I think we discussed it at one time about having a building manager. I know that we have a facility manager. I don't know what they do. I don't even know if we still have that facility manager. We're not in the real estate business. We're in a business of providing services. And we should never have been put in a place to be in the real estate business and spend all of our time talking about rents and rental. I don't think anybody here has the time to go out and actively seek someone to rent our building. And that's part of the ill-conceived plan that just fell apart. So, forgive us for asking questions. That's going to be our job. And I hope that we're not rebuffed like we were on discussing finances.
No, and I do think too, I mean, I did a lot of historical data and I hear what you're saying. So there was a point where we were doing monthly presentations. Every month we did a building update. But I do understand what you're saying about some of that dialogue. In regard to one of the reasons in the presentations as I was looking back at them was it was an opportunity to protect our community dollars as well. The investment in the building, those dollars could not be rebased, and we were not sure at that time how much of our Medicaid would decrease. And so it was an opportunity to secure some of the community monies. I think that was part of the very early on discussions, but there were a lot of discussions and a lot went on, and so it changed a lot. And I do understand what you're saying. And no one's ever offended by questions. We spend a lot of time actually trying to predict if we present something, where might this lead to, and are we ready to answer it? And if we're not, can we go back and get that information?
Here. We got the building. We own the building. It's a beautiful building. We serve a lot of people. The program of buying the building changed. But nonetheless, we're faced with affording the building. And where is the money coming from? And when I use words like fluff, that's not an insult. That is, well, you can take it any way you want, but don't take it as an insult, okay? We have the building. The issue now is, what are we going to do about it? And is the board going to be kept apprised of what's happening? I love this idea about having a committee. That will save a lot of your time. That's not going to add time. I've heard for years, we don't need any financial committee because we can't afford to take up the staff's time. If we did it right, it wouldn't take up the staff's time, it would have helped staff. And at the risk of civility, that didn't happen for the wrong reasons. Well, now we have an opportunity, and the opportunity is to understand where is the money coming from for the build-out? We heard about building it into rents. You may have had a lot of experience in that, philosophy of building it into rents. That's good. It can happen. How about a lease sale back or a sale lease back? I was in favor of getting that financial, paying off the bank. I was the one that urged and suggested. I still think it was a good idea. The bad part about it is the board thought that money would help reduce expenses. Instead, it covered expenses. That money would be better used if we applied it to reserves, but we didn't. So we got challenges, and whether you like it or not, we got to resolve them. And I hope that we lean more towards resolving our challenges and living with what we got and doing it smartly. The build out. I think it's very smart for somebody that wants to rent the building to say, okay, I'll give it to you over 20 years or 15-year lease or whatever. We don't know what's going on, and the board doesn't know. And I think the board should be apprised of this.
We already said we're open to having a 3-time-a-year work group. I mean, every time a suggestion has come up about a forum or a way to work more collaborative, we're all for it, Sid. Civility is something we would love to see more of.
I really agree with you, and I've told you that before, okay? Things are different since you came on board. Things are going to be different every time we get a new board member. And they're going to get better. I don't see the resistance that we had up until you came on board. And I compliment you for that. I compliment the staff.
The staff want to work collaboratively. So I do want to say, using terms like fluff, though, it implies something. So I'm a social worker. I'm sensitive to words. Kindness is my mantra. Let's all be kind to each other. We all want the same thing. So even when we're having tough conversations, I do think smaller conversations could help because we've got to learn to trust each other. And we've just got to get there. we've got to learn to trust each other.
As long as we have the facts, okay, we'll trust each other, and we'll get out of this.
And I believe we're trying to give you
And we'll
everything
get
you're
out of it
asking for.
together,
Okay.
without forcing staff to work, 18-hour days.
Trying to give you all the facts, and we're trying to answer your questions, so.
I'm going to go on to the feel-good part of my job. And Hadass had asked about this. When we looked at the priorities of this building and we were coming in because of the size, we took a great deal of time working with our partners and our providers and saying, how do we utilize this space at a level where it becomes a true connection for the community, not just links and services, but to strengthen our partnership. So this is just, and I am saying this again, very high level, not complete, just what we could pull together in that time frame. These are the organizations that either use this building routinely in partnership with us. They have their own events here. Most of the time it's in collaboration with us for community events. So we work very closely with the Health Division. We work very closely with Oakland Community Schools. All of our suicide prevention events are held here. But these are organizations that have meetings here. They have special events here. We made the commitment very early on that as part of our network, it would be an investment in the community. So we do not charge our partners to use the space.
A good example of fluff. To get from our providers.
So what we had said at that time specifically was that if our providers were using this space, they would not then be spending money to rent. So that's how that conversation went when we talked about our providers would be able to use this without renting space. So these are events, by far not all of them. These are our larger events that we hold in this building at this time. But there are events going on in this building every day. Only one time did we run out of tables and chairs, and we found enough, but that is how much happens in this building every day. So about 1,500 plus just for these events. Trish has given this presentation to you before. About 4,200, 4,300 people participate in trainings. Those are trainings that we host. And but there are other trainings that take place in the building where people ask us if they can use it. One of the things that's really nice about our trainings now is that staff don't have to go places for their CEUs either. And actually, members of the community utilize a number of our trainings. And what is it that's doing for us, too, is building trust and credibility with us as a mental health leader in this community and our true influence and commitment to people. So far, we've had 129 trainings provided. Does that include rights, Trish? Yes. Okay. And those are trainings in this building. 150 social worker CEUs are attached, so average 33 people attend each training. These are the types of trainings. I know you've seen this list before, but these are the types of trainings that we are hosting ongoing in the building. Normally, these are the organizations or places where we would host, depending if it's an all-day training, it can be anywhere from $750 to $1,000. We usually, if you're on site, you have to pay extra for AV. Some of that, a training may be every day for 5 days. So we originally estimated about 10,000. I think actually it's closer to 20,000 what we are not spending and leasing money out and time and space and AV, not to mention for our staff. If we were going somewhere 20 minutes away, we usually spend a half a day packing up things, transporting it to where we need it to be, another half a day unpacking, and then the same at the end of the packing up and bringing home. So staff time-wise, we are saving days in it being able to come downstairs, have our own staff here, have our own AV equipment. I will do a deeper dive in terms of what we think we're actually spending high level because of the time, and I did want to put that perspective in there, but I thought about this Friday, and Annette was there, Kathleen, Vicki. We had our work group appreciation event. All the things we do in this building, I promise you, nothing brings us closer to why we're here than when we get to sit around and laugh with the people we serve and talk with the people we serve and listen and hear them and be important parts of their lives because they are important parts of ours. And that is something that we did not have in the other building because we didn't have that space. And there is another element of pride and dignity the people we serve feel when they walk in here, that they are deserving, they are valued, and that we believe them to be important. And I don't know that in all the I'm not a financial and I'm not a social worker, but I'm probably more touchy-feely like Annette. I don't think you put dollar amounts on what we saw Friday. Kathleen and I both said it just took a deep breath of all the hard work we did and walked away and thought, boy, we are so fortunate in the roles we are to work with the people that we do. Have any questions about my feel-good job? I have lots of answers.
So I know that we bought the building from Friedman. We had them do the build out. I thought that they were managing some of the aspects of the building, and I thought they were helping us pursue the empty space. Is that still accurate?
So they don't manage anything. That was transitional until we were in the building because it was vacant. We wanted somebody that was in the vicinity to manage it. It's actually called a different company now, I believe, but they do have the listing agreement. I don't think it's actually current anymore, but they are the ones still currently showing it, yes.
I know you can't talk about things.
I
but can you not?
honestly haven't even looked at it yet. So all I did was see it come in my inbox, that was it.
Here say there is somebody who has an offer on the first floor.
Just
Oh, yeah, we
heard
do.
there was a rumor that someone was interested in on
No,
first.
so I have someone that I believe is interested in the first floor space, but I have not even looked at the proposal yet.
Call I've gotten about anybody interested in the entire second floor said only if we will expand their contract to give them more Medicaid funding. So I said, we are not entering into any back alley deals, negotiations about bigger contracts in order to rent an entire floor. So if anybody knows of anybody, I'm assuming that's who you were asking about, Dr. Tobit, study session, but you said maybe not. I'm not aware of anybody looking to rent the entire second floor because we would love to engage in a legit business dialogue about a tenant if there is such a entity.
I know that some of the staff here know I'm a fan of if we can bring in a third party, and someone we don't contract with today. So then the revenue that's coming into us would be.
We're open to any tenant at this
Yeah,
point.
so at this point, it's been opened up. It's not restricted in any way, shape, or form.
When you say any tenant, is that, I'm just trying to grasp here. So we're looking outside of service providers. We're looking at everything.
Yep. I think as a board, we decided that maybe 8-9 months ago, so we opened it up quite a while ago. We did say, obviously, if it was like a marijuana distributor or something, not in line with our values, but other than that, yeah, we're open.
So yeah, it's on the MLS listing. It can be looked up. It's not private or anything.
Then who's charged with the responsibility then? Is it Anya who does that as far as finding the renter, or when the renters have a proposal that they want to bring? Is it?
We have a listing agent who does the majority of the showing and all of that stuff. Then I have like the proposal that leadership would then take a look at. If we think it's viable, we would bring it to you all. But otherwise.
There's somebody else doing that work.
The legwork, yes.
Okay. And then the $20,000 is the approximate cost that you're projecting in rental savings, correct?
Oh, that's conservative. I mean, that's, Tricia and I really just grabbed that at the last minute, looking high level. So I will do a deeper dive and get some more figures for you. And if we were renting out space for all of our trainings, what that would look like.
And I think it's, it's great.
Fine.
The trainings, and, it's beautiful. My wife's a social work therapist, and she's been here several times and has been part of the trainings. And I think it's good that we can offer the education credits as well for people. But, on the other end, my administrative sides, my administrative side tells me that, it's nice to have things, but we can't always afford what we want, and I just want to look at it from a realistic standpoint. No, that's it. Thank you.
the pushbacks that you've gotten over the last 3 years for renting the building?
When you say pushbacks, you mean potential tenants that chose not to rent? Or
What reasons?
the biggest reason I heard is the Troy area has a massive amount of rental space available. Yep, so we're competing with other buildings, other locations. We were real hopeful that one of our neighbors down the road was going to, I guess that might be the one you were thinking of. At one
Flagstar Bank.
time, they were thinking about, and they were looking at 3 different locations. Maybe that's the one when we heard about the second floor, because they did talk about taking a big space. They came and toured 2 or 3 times. We talked about the parking lot and even allowing them to use more parking spaces for their overflow. All I can imagine is they got a better deal from some other building right here in the vicinity.
That was the one where they ended up they did a space shift to do it, and not have to go outside, that they shifted people internally.
That's exactly the understanding I had.
Maybe that was the one that was being referred to at one time. They were an option. Or hopeful, we were hoping they'd be an option.
What I brought up was that I had heard, and I don't know the name of the company, that somebody had really wanted to rent a whole floor, and nobody returned their phone call because they were not a NGO even, or.
You're talking way back when we were only looking for, okay.
Right, and they wanted to, and their phone call, they called in, and their phone calls were not even returned, because Willie wasn't interested in them. So,
I can't speak to that. Now we will return every phone call. I can't speak to decisions in the past.
There really isn't too many pushbacks other than right, there's too much other space. What is the pushback? Is it rent? Is it build out? Is it?
The one I heard was an attorney's office. They were not interested. It's a little busier here than they wanted. They wanted a quieter space. That's one of the few that I've heard recently that did tour. This isn't really what they were looking for. They don't want the busy hubbub of this.
Bottom line is there's not a lot of interest.
That would be
Better
accurate.
than what we're getting.
That would be accurate.
That's
We had some leads at one time, and I was sending you emails, and then, I mean, this one that they have visited now a couple times, I mean, we're like, oh, let's hope, but we haven't got a lot of leads since the communication I gave you several months ago.
All right, so dashboards. So one of the things that came to my attention, and I want to apologize for, is that it appears to be that there's confusion over access to the dashboards. So what has happened in the past, even though as a CIO, this makes me cry a little bit inside, is that there is a shared account, Jonathan knows exactly where I'm going, is that there's a shared account to access the dashboards, and there are dashboards that were developed for the board well before I got here. That account is still there, is still active. So what will happen is, number one, I have talked to Annette and said, you know what, when we onboard new board members, they need to know that that is out there. So that got missed. And when, it will probably not be today, I'm assuming it will be tomorrow, instructions will be sent out on how to access the dashboards. There's a link on our website. And then you will get a separate email that has the password in it. Because once again, from a security perspective, I just want to have, because someone said, oh, can we put it in the same email or same document? And I'm like, no! So you will get both of those tomorrow. If you guys would like an additional tutorial or how to navigate them, we can do that at a study session. Dashboards that are available to you are case management by core providers, inpatient hospitalization information. You hear us talk a lot about eligibility, persons receiving ongoing services, quality of life outcome measures, and a scorecard. One of the things that I do want to say is when I started looking at those dashboards, and I know that some of the requests that I've heard you as a board make, and even when I was in the interim CEO position, I knew that there were certain things like people served by population, for example, or by provider. Those aren't available. So one of the things that I'm requesting from the board is that we sit down and we have a dialogue about what kind of dashboards that you would like in the future. And the reason why I'm tying this into the future is because remember I talked about how we're moving to a new dashboard system or application. What it's giving us the opportunity as an organization is to look through all of our dashboards and determine what are we using, what are we not using, does it have the information we need or not? Because we have some that have been developed years and years and years ago and no one accessed, or they're just not meaningful anymore. And so that was when I was looking at some of them for the board, I'm like, oh, I think there's some things in here that you guys would, I assume, like to see. And some things in there, like the scorecard was developed a long time ago, and it's probably not going to have as much meaning into it as what you would like. So as I said, you're going to get instructions on this, but when you go onto the OCHN website, up in the upper middle, I guess, on the right-hand side, there is a link called Provider and Staff Links, and I think it is going to be changed to have the word also board put in there. After you click on that link, you go down on the left-hand side and click on iDashboards, Reports, and Data, and then you're prompted with a login. So one of the things that I mentioned is that it is a shared account, and it does lock if you enter the wrong password 3 times. In those instructions is the phone number for the help desk that you can call, even if it's on a weekend, leave a voicemail, and when we get in on Monday, or if it's during the day, we would be able to unlock that account for you.
So to clarify on that, that's still a board-wide shared user ID password. All the data in it is de-identified. So it is safe. We still don't want to share it with others. It's for our own consumption.
Any of it that's in there could be requested by anybody, and as you said, there is no protected health information in it. Yep. Thank you for clarifying that, Jonathan. I appreciate that. As I was flipping through my notes. Are there any questions from anyone?
I have one if nobody else has one. We have different emails now. Does that matter what email you have?
Does not, because you're using that shared account. So it's called OCHN board account, and then you will get a password that goes along with that. So it has nothing to do with your email. It's not tied to your email at all.
When you say a board account, I guess I don't, because at one point, we could go on the website and click on board. That's still available to us?
Are you talking about the Google board stuff?
I don't know.
I think you might be talking about what we had in Google, and we don't have that anymore, but we did recreate it in Office 365. It is still available, if anybody wanted to have the accounts that go along with that. So you would have to have an OCHN account for that.
That's the question I was trying to ask.
That is separate. I just want to make sure that I'm clear, that is separate from the dashboard login.
If you go in on that account, okay, never mind, because I'm.
So you're going to go to our actual website to access the dashboards, oaklandchn.org.
We're going to get a password separate from the instructions. Is that password going to change every month like the?
So that one, once again, I cringe a little bit inside. But we are starting to see changes. That one will not change.
Okay.
Our
Our board password used to change all the time. Plus, it was a 2-step sign.
And, and we can go into this more if we wanted to have some more dialogue. I think, I know what happened when we went to 365. What we had is we had some things that we're seeing as being related to 365 that weren't really 365 related. What we did was we strengthened the security in general when we made that move. And the other thing that is hard, it's not that we don't want to be customer focused and as friendly to the board as possible, and we always try to do that. But I can't have for certain things like password criteria for me versus you. We literally cannot do it without creating a whole bunch of other challenges. I worked for a very large city in Arizona, and we were going to do that, and it just wasn't going to be worth it. So that's part of what I come into when we're trying to work through some of these things, is saying it's very difficult for me to have, and not just me, but for us as an organization, to have a separate set of rules for board logins to be able to pass our HIPAA audit that we are going to have. We're going to try having one this year. That's our goal. Of the, health information for the people that we serve. Any other questions? Dashboarding.
Or problems after we try.
There's nothing else on that subject. This is our second opportunity for public comment. Is there anyone in the audience that wishes to make public comment at this time? I don't see anybody charging the mic. Okay, director's comments?
I'll try to make this fast. The Community Mental Health Association of Michigan has a vacancy open on the executive. I'm looking at the top because I know the executive membership, so the executive board. And it's a PIHP appointed position. So as I understand it, I met with the PIHP CEOs last week or last month, and they said there's a rotation. There was another PIHP identified to appoint somebody to the vacancy on the board. It has to be the CEO or a board member. That CMH did not get anybody interested from their board that wanted to serve, and the director did not want to serve. So they opened it up and said, does any other PIHP have an interest in filling this position? I know I had informal conversation with Hadass, and we all know that Dr. Taub's been involved with the CMH, Jonathan's been involved, Melchia's been involved. I hate to let the opportunity pass us by to have a voice on the executive board. So I guess I just wanted to put it out there that we have this opportunity. If you have an interest in being on the board, that might make the reasonable first step. Like, email me if you have an interest, and if nobody's interested, that'll be one discussion. If 5 people are interested, that'll be another discussion. But go ahead and email me, I'd say in the next week, because they're looking to appoint that position within the next 30 days. My understanding is the executive board meets the night before the conferences. And I'm looking at you guys, is that, so let's say, whether it's in Novi, in Kalamazoo, or up in Traverse City, you would come in a day before to meet, no?
Every other month.
Oh.
The executive board meets every other month, and then the steering committee meets alternate months.
Oh.
A lot of those get canceled, but the executive board meets, and then when there's a conference, it meets the night before the conference.
Okay. Thank you for that. I personally have not been involved, so it sounds like it'd be every other month commitment if anybody was interested.
6 meetings in a year. Just wanted to put that out there.
Including the 3 conferences. The meeting that month is, okay. Yeah, so it's 6. And the meeting is, I don't know if they changed the time since.
Lansing, Dr. Tubb?
It's at CMHA headquarters.
Right, but they also do
Dial-in, but they have teleconferencing, but they're not using it. But it's a 3-hour meeting. It's from like 9 to whenever they finish around noon.
What do they talk about?
Everything that Bob Sheehan has.
3 hours might
There's
be
like 45 people on the
conservative.
board. There's usually about 25 or 30 people at the meeting.
Okay. So since the timeline is tight, they want to vote the person in at the October conference, and if we're not going to take the slot, some other PIHP surely will. Are we okay with saying, if you're interested, let me know, like in the next 5 days, and then we could talk about it at our board meeting or decide, and I could even kind of email you guys or Judy, these are the people who said they are potentially interested, and we can go from there.
Any more detail on the job description? for fear of overusing a word. Because I think people would need to know what kind of responsibilities, what kind of areas of expertise, what would be helpful in moving that board forward.
In general, that board is made up of, from each CMH, director, member, and a board member. So there's two already from each CMH, or from each region, excuse me. And then there, yeah, no, right, yeah. And then they have like 10 different committees, and they all report, and that's in the consent agenda. And they might have some things to discuss, so you go through. And then Bob Sheehan is arranged, and then the president is Joe Stone now for an extra year. So he runs the meeting. And whatever comes up, everybody, you think we're a diverse board. I mean, this is 42 people from all over the state. In some of the states like Alaska, some is like, downtown Detroit. So a lot of different, so everybody talks, and it's a hard meeting to manage. You think 12 people is hard to manage, but 42 people. And it's if you go to that meeting, you'll know every single thing about community mental health in the state. You'll hear it on the committees you're on if you want to join a committee too. A lot of the people that are on the board are on committees too. And I found it really interesting for as many years as I was on there. And having to run it for
I
2
did
years.
email them and ask them to send me something. Obviously, this came up at the meeting on Thursday, so I mean, I haven't gotten anything, but I could forward anything I get. But pretty much right now, I think the PIHP directors are looking to say, is Oakland interested? Do we have someone to take the slot? And if not, we'll continue the search amongst the PIHP. The CMH Association doesn't fund us. We pay them.
Can I say one more thing? Since you mentioned that, they meet periodically with the staff of the department. So Linda Zeller used to be there every month. It was hard to get any information out of her, but some of her staff, if she was sick and some of the staff came, we could get some more information. But you really get to know, and legislators will come, and different groups that want their endorsement on certain issues will come. So you really learn a lot more than you do like sitting at these meetings. I found it really interesting. And you get to know people from all over the state. And the reason I got on originally is because Oakland County is envied and coveted by a lot of the state. That hasn't changed. And having a real live person there, like you're there, as many Oakland County people you can get to have personal relationships with 42 other people really helps our image in getting along with everybody. So I would urge anybody that, can drive up to Lansing once every other month to do it.
End of your comments? Open up for board comments. Steve?
Okay, just a couple of quick ones. Reading the CMHA weekly update, I noticed that 2 PIHPs, which is Detroit Wayne and Kalamazoo, are changing their name to include the word integrated. And I know now is there going to be a time when the legislators who don't know anything about community mental health are going to decide on things by looking, these two are integrated, so do we need to stick the word integrated in the middle, like OCHN or something? I'm just saying, something food for thought, because 2 have done it already. Okay. Secondly, I know that our group of stakeholders, if you discuss 6 things, you can create a panic, and we always worry about that. But with the Open Meetings Act, we can't get in the position of not discussing something that's important because we're afraid of frightening somebody. What we got to do is add language that will reassure. When you consider something, you consider every alternative. Everything's on the table when you start out. Well, that doesn't mean anything serious is going to happen. You're going to pick something that's going to, and a lot of people that we serve live on the edge. And if you, oh my God, they're talking about, well, you always have to talk about everything. And I think we just got to get over being afraid of that and just do it. We're in open meetings. We have to follow the law, but we have to also discuss things that we need to discuss. And I think in the past, things haven't got discussed because we were afraid of starting a panic. So maybe we should be careful of our language so we don't start a panic. We've got to discuss everything.
Were you done?
I'm done.
Are there any other board member comments? I have just one. I will not be able to attend this month's CAC because I'll be at a training in Connecticut. So I don't know if there's another board member that would be interested in attending that meeting. It's the Wednesday morning after our Tuesday night meeting.
So people might still be here and they can just go down the hall and.
I keep asking for a room and a shower and a bed.
You have that.
A bed, a TV,
I think the TV might be the.
a jacuzzi. I keep
stumbling
asking and I can't get them. I don't know why I can't get them. But anyway, I won't be there. So if nobody's able to, then there won't be a CAC report for October from the September meeting. That would be nice. Thank you, Christine. Are there any other board member comments? With that, we are adjourned.